Okay. Okay. Hi, guys. So I'm gonna do a little bit of histo today. I did ask this was something again that Dr. Demarest had like emphasized that I went over, even though it's kind of hematology and you're gonna get it again next year, but she said there were some histo questions on the exam last year. So I asked Dr. Milani if this was something she wanted me to go over, and she said yes. So assuming there's also gonna be some histo, but like I did it so that there's a little bit more info than you need, but that can be for like next year. But I'll kind of tell you what to focus on. It's going to be more so kind of understanding like if you were to get a vignette and then see the smear, could you identify what cell that is? So could you kind of use like the history, like the symptoms, whatever, and then see the cell and then identify what it is. So that's kind of more so what to focus on, not so much like reference ranges and stuff. That's just like extra for hematology next year. Okay. Okay. Okay, so we're going to start with peripheral blood smear, go into the histo, whatever, and then end with vaccines, which is going to be kind of like a culmination of like your B cell and T cell stuff. So it's going to be kind of cool. You can kind of see how it all kind of comes together. I've been talking about vaccines for like the past week. They're very exciting. Okay, so this is kind of your, I think I put this in like one of the first lectures, that you should kind of know this like tree of like the precursors and whatnot. I highlighted here, I put a box around the NKT cell precursor because that's like a classic question to understand that NK cells come from the same precursors that T cells come from. And again, it makes sense because like they do the same thing as T cells. They're just in the innate immune system. Okay, but just kind of wanted to remind you guys, this is what they look like. And now we're going to actually see it on the peripheral blood smear, what they look like. So this was also kind of like, I highlighted here the ones that are in the blood. So these are kind of ones that you're gonna see in a peripheral blood smear. Some other tricky ones, like we talked about mast cells, how like mast cells and basophils differ. Mast cells are in the tissue, basophils are in the blood, that type of thing. So just kind of having an idea of where these cells are, so you don't pick like, oh, if this is a peripheral blood smear, I shouldn't be seeing dendritic cells, or I shouldn't be seeing mast cells in the peripheral blood smear. Okay, so we're gonna start with white blood cells. So this is what your neutrophils look like. So they're neutrophils. Other names for them, remember, are PMNs, so polymorphonuclear cells. And then you can also see them called SEGs. And they're called polymorphonuclear cells because if you notice, they have many lobes to their nuclei. So polymorphonuclear, it's like many morphologies, but it's really like many lobes to their nuclei. So this is a PMN, here's a PMN, whatever. This is a type of granulocyte. So if you notice, they have like little granules, like little dots here. That's like all the granules within it. These should be like the highest percentage in your blood, in your CBC when you order a CBC. If you have high levels of neutrophils, think bacterial infection. And this can be something you probably have realized this from doing cases, but if you have high neutrophils, think bacterial infection. But what's really, really, really important is you should see 3 to 5 nuclei, like lobes to the nuclei, but no more than 5. This is another type of cell if you have more than 5 nuclei. So here is these are good pictures of nuclei. So here's 1, 2, 3. That's like maybe a fourth one. 1, 2, 3, 4. So that's kind of, even this is like 1, 2, 3, 4. So it's kind of like that's kind of what you're looking for to identify this as a neutrophil. And then they kind of pick up like a little bit of a pinkish stain. But yeah, this is your classic neutrophil. And again, I'm highlighting all this stuff because this is like there's like different versions of neutrophils, which we're going to talk about. And like those are different pathology states if you see those. Okay, so neutrophils, PMN, SEGs, all the same thing. So these are bands. Bands are basically like more immature neutrophils. And what's really important about bands is that they don't like completely segment. So again, we're talking about like another name for neutrophils is like a segmented cell because the neutrophil segments into like these different segments. These are just kind of, they look like C's. Like the nuclei literally just look like C's. Like there's really no segmentation. Like this doesn't break off into its own nucleus, and then this doesn't break off into its own one, and then same here. Okay, so it's basically just one lobe, and there's absolutely no segmentation. The second you see segmentation, that's going to turn into a neutrophil, a seg, basically. If you have increased numbers of bands in your blood smear, that's usually a sign of appendicitis, or it's a sign of a really bad infection. So think of it as like the body's like, all right, I have such a bad infection, I'm going to just start shooting out like more immature neutrophils because like the body needs help. So yeah, and they're normal up until about 5%. Like I said, don't really focus on the reference ranges, but just keep, like, you can have them in your blood smear, but you don't want like the entire thing to be bands and no segs. That's like usually like a sign something's wrong. Okay, and then this is where it's important to know that neutrophils have 3 to 5 nuclei, but no more than 5, because once you hit more than 5, sorry, I keep saying nuclei, lobes to the nuclei, as soon as you hit more than 5 lobes to the nuclei, it's what's known as a hyperseg, or hypersegmented cell. And this is very obvious. There's way more than 5 lobes. 1, 2, 3, 4, 5, 6, 7, 8, 9. Yeah. So this is like just tons of nuclei. Don't count the lobes, like I say here. You can just kind of look at this and be like, that does not look like a neutrophil. That's like a weird looking cell. This is what is going to be really important for hem-onc next year. If you have hypersegs, this is an indication of a macrocytic anemia, which that means nothing to you guys right now, but it is this is what they look for to diagnose a macrocytic anemia, which is like a B12 deficiency or folate deficiency. I think you guys did talk about this with like vitamins in GI block. So this is like what your hypersegs, this is like what you're going to be looking for. Okay. So next are lymphocytes. So we talked about like neutrophils, bands, hypersegs. So here's lymphocytes. Lymphocytes are, so in this image right here, just for an example, this is a neutrophil. So PMN. These are lymphocytes. So see how like they're like a little bit smaller than neutrophils, but their cytoplasm is just like a giant blob, and it kind of takes up like the nuclei takes up like the majority of their cytoplasm. That's like an indication that it's a lymphocyte. Also, lymphocytes are not granulocytes. They really don't have granules in their cytoplasm. So like here are lymphocytes here. Here's one. It doesn't look like spotty like how neutrophils look spotty. Like here's another neutrophil. See how spotty it looks? These really don't or shouldn't look spotty. They just have like a giant nuclei taking up most of the cytoplasm. Something important to know is that if you look at this, you cannot tell if this is a B or a T cell. You know it's a B cell, you know it's a T cell, but you don't know which one. So that's like an important thing to understand. You know it's one of the two, but you can't differentiate. These are the next highest number present on a peripheral blood smear. So your neutrophils are the highest, then your lymphocytes. If you have a lot of lymphocytes on your peripheral blood smear, this is where you think viral infection. And hopefully this makes sense after like the T cell lecture, especially because you really need T cells to get rid of viruses. These are small-ish. That's why I kind of write here. They range in size. So like you can see in this image, this is a lymphocyte and it looks almost the same size as the neutrophil. So it's just kind of like use more of like this whole idea of, use kind of more of this idea of like the nuclei is almost the same size as the cytoplasm to identify your lymphocytes. Okay, and they're going to stain blue. And then last little note is NK cells also look just like this. We talked about this, but these are usually, you don't usually count NK cells in your cell counts because it's like very, very hard to identify the difference between them. So we just call all of them lymphocytes. They're either B or T cells. Okay. But again, that's kind of the whole idea. NK cells develop from the same precursors as B and T cells. So, well, from T cells specifically. So they're going to look exactly the same. Okay. This is your clinical thing. So this is something cool clinically, is if you have a reactive or an atypical lymphocyte, it looks nothing like a lymphocyte. It's reactive. It's like reacting to something. This is like an indication of mono. So Epstein-Barr virus causes mono. This is what they're looking for if you've ever had mono before and they've looked at your blood, you're going to have reactive lymphocytes. And I always say this, they're reactive because they're angry. They're like very angry lymphocytes. So what I kind of look for to identify these, because you're going to see in a second, these look very similar to monocytes. You can even make like a little note, like these look very similar to monocytes. But what you're looking for is you're looking for the cytoplasm to be indented by the red blood cells. That's kind of what you're trying to look for with these reactive lymphocytes, and they will be indented. Okay. And then a big trick, so I'll give you the trick that they like to ask about, is these are T cells. So you can actually identify, like if you see a reactive lymphocyte on a blood smear, it's a CD8 positive T cell, always. It'll never be a B cell. It'll never be a CD4 positive T cell. In mono, if you see a reactive lymphocyte, it is a CD8 positive T cell. But keep in mind with mono, actually we haven't talked about this yet. I think this is on Thursday. Mono becomes dormant in your B cells. So this is like a classic trick question that they ask. So EBV, Epstein-Barr, remains dormant in your B cells, but the reactive lymphocytes are T cells. They're CD8 positive T cells. Okay? And because, like I said, like you can't, if you just looked at a regular lymphocyte, you can't tell if it's B or T cell. This you can. This you know that this is a CD8 positive T cell. Okay? And then I have down here just like compared to a normal lymphocyte, which looks nothing like this. Like they look completely different. Here's a neutrophil, so PMN. And then in this image here, oops, these are all reactive lymphocytes. See how like the cytoplasm like around the edges is really blue? They're indented by the red cells. Reactive lymphocyte, CD8 positive T cells. All right, monocytes. So monocytes kind of look similar. So here's your monocyte. If I go back, they kind of look a little similar. Like if you were to just scan the peripheral blood smear, you know, they kind of look similar. You're kind of looking for just giant, like very glassy looking cytoplasm. So it looks thin. It looks like the cell was like stretched out a little bit and the cytoplasm looks kind of glassy. These are agranulocytes. Remember, the only granulocytes are your neutrophils, your basophils, your eosinophils. So these are also agranulocytes. Remember that these are not macrophages. Macrophages are in the tissues only. I haven't seen a trick question like that before, but I wouldn't put it past anyone to ask that. If they gave you the option, is this a monocyte or a macrophage? These are not macrophages because we're looking at the blood smear. But there's a ton of different shapes to these. These are actually kind of hard to identify, so you just kind of have to go off of like the big cytoplasm, the big nuclei, like they're just big cells basically. So I even put here, like in this picture here, these are all monocytes. What they classically say is there's the kidney bean shaped nucleus. So that would be like this. This is like your classic kidney bean shaped nucleus. But as you can tell, these are all monocytes. They're not all beautiful kidney bean shaped. These are all monocytes. This is a good one. They can be increased for a whole number of reasons. I mean, these are eventually going to turn into antigen presenting cells. They're going to eventually turn into macrophages in the tissues. So you can see them like increase in a bunch of different stuff, but these are going to be the absolute largest cell on the blood smear. Like again, monocyte, like they're mono for one nuclei, and it's just like they're just giant cells. And then again, so like if there's holes in the cytoplasm, that can usually also be like another indication. Like, but again, not all of them have holes. They're really kind of hard to identify. So here's more holes in the cytoplasm. Again, I just kind of look at like the very glassy. I don't know if that makes sense what I mean by glassy, but it's almost like see-through. Their cytoplasm looks kind of see-through. Here's like your neutrophil, which is like a little bit smaller and has like the dots. It's a little bit more opaque, the cytoplasm. And then just a trick for blood smears, if you're ever debating between like what type of cell, I've done tons of blood smears like when I worked in a hematology lab. When you're like debating what type of cell it is, you just kind of like, we call it the company they keep. So it's like if you see a bunch of monocytes and then you're like, I have no idea what the cell is, it's probably a monocyte. They're in the company of a lot of other monocytes. Like this looks completely different from the rest of them. It's still probably a monocyte because it's keeping the same company, if that makes sense. Okay, good. Eosinophils, really easy to identify. I think this is the one that they asked about on the exam for like my year at least. I think they change it, but they're easy to identify because they're just giant pink granules in the cytoplasm. So these are granulocytes, right? Remember, eosinophils, they're a mediator releasing cell, so they're going to release a mediator. Here's like the pink, they literally stain pink. They stain like this. And then here's a lymphocyte down here. So you can kind of see this as a giant nuclei taking up pretty much the entire thing. So they kind of look like neutrophils, but they have pink granules. And then with eosinophils increase, you're going to think allergies. You're going to think worm infections. So like helminths. Remember we talked about ADCC with the eosinophils. Remember IgE is going to bind to the worm. And then the eosinophil is going to come in, bind with its Fc epsilon receptor, and then release its mediators to get rid of the worm. but also parasite infections in general. That's where you would see these increase in eosinophils. So this I think is like a very clinically relevant one, because if you have an increase in eosinophils, it's only going to be one of these three. But again, they do just look like bright pink neutrophils. Usually people say they have bilobed nuclei, but they don't have to. So like they're saying 2 lobes. So here's like 1 here, here's 2 here. Not always. So again, just kind of like take that with a grain of salt. But it's really the pink. That's how you're going to identify it. The pink and the giant granules is how you're going to identify eosinophils. Basophils are kind of like eosinophils, except being giant pink granules, they're going to have like giant purple, like very, very purple. It's to the point where you can't even see the nuclei because of how giant and purple and the granules are. So here's a basophil. See these ginormous purple like granules? Yeah, this is how you know that this is a basophil. Here's a basophil here. I know you can't really see the granules as well in this bottom picture, but you can't even see the nuclei, and because it's just like a sheet of purple. That's your classic basophil. And then over here, I would say here, this is a monocyte. So this would be a monocyte or a reactive lymphocyte if this patient has mono. Can't really tell. Here's a neutrophil, so PMN. Down here, this would be a PMN. And then over here, this would be a PMN. And then these would be like your basophils. It's classically what they look like. Again, I've only ever seen one basophil in my entire life. They're really, really, really rare to see like in the on a blood smear. But if they are to be increased, think allergies. The granules within basophils are actually histamine. Again, like someone asked on the first day, like basophils and mast cells are very similar. It's just like one's in the tissue, one's in the blood. So of course the granules are going to be the same as what's in the mast cells. Mast cells release histamine. This is why you take antihistamines when you have allergies. Kind of the same idea with basophils. But again, you really just can't see. That's how you're going to identify a basophil. You can't even see the nuclei. Okay. Next is plasma cells. So plasma cells shouldn't be in the peripheral blood. So remember on like that one slide I have, like plasma cells should be in the bone marrow, right? That's where they should be. They really should not be in the peripheral blood, but if they are, this is what they look like. And they classically like to ask about these because of this like idea of this perinuclear halo. And it's a good like kind of physiology tie-in. But before we talk about that, it's like a very round cell. So it's very round. And the nuclei is what's known as eccentric. So it's not going to be directly in the middle. Like it's not going to be like a beautiful circle right in the middle. It's going to be off to the side. So it's going to be eccentric. These are good pictures of like the nuclei being eccentric. It's more closer to one side. Here, these are all plasma cells here. So like right here, right here, right here. These are all plasma cells. So again, looks like a lymphocyte, but it has that peripheral nucleus, that eccentric nucleus. And then this idea, the perinuclear halo. So remember, plasma cells are when you activate B cells and you get the effectors, you get plasma cells, you get memory cells. Those are like the B cell effectors. Plasma cells, remember I said, like, just think of these as like antibody factories. So they're just churning out antibodies. They're like, all right, we made these antibodies against this antigen. Now we're just going to churn out tons and tons of antibodies. So they're churning these out like over and over and over again. Antibodies are proteins, right? They're just made up of like protein, like amino acids. This perinuclear halo is basically just like rough ER. So it's almost like the cell, it's like showing that the cell is like churning out tons of protein because it has just very enlarged rough ER, and that's what's making the white. You're not staining the rough ER. So it like leaves like a white space, and they call that a perinuclear halo. So peri, like to the side of the nucleus, and it looks like a halo because it's white. It's not stained. Does that make sense? So the perinuclear halo is basically the rough ER expanding because these things are just churning out antibodies, which are proteins, and then that does not get stained when you do this staining for your peripheral blood smear. Okay. And again, you usually don't see these on a smear. If you do, that's like a pathology. You can learn all about that in a Hem-Onc next block. You don't have to worry about that right now. But if you were to see this, it's this perinuclear halo. That's kind of the physio concept from this. Not even physio. It's like molecular biology, right? More rough ER, more protein, doesn't stain when you do the stain. Okay. So you guys are going to identify these cells. So you can chat me. What do we think A is? Okay, cool. Yes. So a lot of you guys said PMNs. Some of you guys said bands. Totally fine. This technically is a PMN. I know it's like, again, it's like kind of like the more you see it, the better you'll get at identifying it. See this like little indentation here? Technically, this would be considered a neutrophil, not a band, because we do have like this indentation. If you go back to the images on the bands, it's fine. A lot of people said, like, you guys are like, oh no. A lot of people said bands, and that's fine. I would have actually like probably accepted bands if this is like your first time ever seeing it. But as soon as you see this little indentation, it's segmenting. Boom, it's a seg. So this is kind of like your, if you go back to the picture on bands and kind of look at how this compares to and be like, oh, okay, I see. It's like the bands are like a more beautiful C nuclei. All right, good. So what do we think B is down here? Awesome. I was hoping that at least one of you guys would get got and say macrophage, but none of you guys got got. I'm very proud. Yes, this is a monocyte. It's the exact same cell. Macrophage is the exact same cell, but again, macrophages are not in your peripheral blood smear. Macrophages are only macrophages as soon as this leaves and goes to the tissues. Awesome. Okay, what do we think C is? Wow, you guys are much better than last year's class. Don't tell them I said that. You're much better than their class. Okay, very good. This is a lymphocyte. Awesome. And again, I just keep in mind the different shapes and sizes you can see of the lymphocyte. But if you see nuclei almost the same size as the cytoplasm, that's going to be your lymphocyte. This is a really big lymphocyte. I would say like they don't all usually look like this. They usually look like, usually what they say are lymphocytes are the same size as red blood cells, which is what these other guys are. So you can see the wide range and the different sizes of lymphocytes. But just look for that nuclear and cytoplasm. Like look for that ratio. Okay, D. Okay, good. So this is an eosinophil. So the people that said neutrophil for this one and the people that said eosinophil for A and vice versa. This, can you kind of see the difference between these two? If you were to kind of look at these two side by side and be like, okay, yes, I understand, like, this is very pink. This is a lot more pink compared to this. And the granules are like a little bit bigger. It might just take like just looking at a bunch of blood smear slides to like really fully get the difference because they look the same minus the color of the cytoplasm. But good, this is an eosinophil. All right, what do we think E is? Okay. Okay, so this is, I was trying to trick you. This is another neutrophil. Good. So this is like another version of a neutrophil. People that said reactive lymphocyte, I get what you're saying because the indented cytoplasm, right? But reactive lymphocytes look way more like monocytes. They have like the giant like the nuclei. It's not going to be segmented like this. As soon as you see the segmentation, it's still going to be a neutrophil. So this has like 3 to 4-ish segments to it. even though the cytoplasm is kind of indented around the around the red blood cells, this is still going to be a neutrophil. Okay? But I totally get it with the indented cytoplasm. Okay, and then lastly, for the white cells, what is F? Yes, you guys are going to love identifying. Yeah, it's a good one, right? Ooh, one of you guys got, and I'm excited. So you won't get got on the exam. But so this is a basophil. Very good. This is not a mast cell. Mast cells are only in the tissues. Only in the tissues. So this is, if you're in a peripheral blood smear, you should not see mast cells. They're going to be in the tissues only. So if you're, again, between the two, be like, oh yeah, blood smear, blood, basophil. Okay, very good. So the giant purple granules, can't even see the nuclei because of how big the granules are. Awesome. Guys are little hematologists. All right, and then what's G? We already kind of talked about. You did get got, but that's okay. You won't get got in the exam. Okay, perfect. Yeah, so this is a red cell. G is a red cell. It was just kind of showing like all of these around here are red cells. What do you guys think this is here? We didn't talk about it yet. So what I just circled, what do we think this is? This is technically, yes, very good. Very good. Awesome. Yeah, so this is a platelet. So this is what your platelets look like. Platelets literally are like, again, you'll get this. Actually, I don't know if I talk about it in this. I forget. But they're literally like megakaryocytes. So if we go back to the branching, megakaryocytes are like the biggest cell in the entire like bone marrow. They're mega, right? Mega, giant, just the most giant cell ever. Pieces of its cytoplasm break off. That's your platelet. So it literally looks like it breaks off. And then someone, or a couple people actually said plasma cell, which I get it because it's like pretty much the same size as your red cells, but those are going to stain purple. They're going to look more like lymphocytes versus your red cells, which are going to be like, they're not going to stain like purple. They're just going to kind of be there. These are kind of like what your red cells look like, erythrocytes. Everything you guys said was perfect. Okay, makes sense. If you can identify these, you probably will be in good shape. Okay. So we're going to switch gears to red blood cells. This is kind of where there's a little bit more info than you guys actually need because you're going to go into a lot more detail in hemonc. But there's some inclusions that we have to talk about, especially remember we talked about if you don't have a spleen, there's certain inclusions that you see. So I'm going to show you kind of what they look like. So this is what your red cells should look like. So they should look what's known as like so they're biconcave. You guys know this, right? Palm. So they're biconcave because they're carrying oxygen. They look like donuts. So you see what's known as a central pallor. So you want to see a little circle of clearness inside of them, like in the middle. This is your central pallor. And again, this is, if you know what a red cell looks like, it's kind of like dish-shaped. It's a horrible drawing, but it kind of indents on both sides. That's why it kind of looks like a donut if you were to look at it straight on. So this is what your normal red cells should look like. So if you have microcytes are just like really small versions of red cells. So I put the pictures with the lymphocytes in here. So this is a lymphocyte. I will always just try and identify the cells in here. They should be around the same size as like a small lymphocyte. So not the one, like not this one back here. This is a ginormous lymphocyte. So I would not say that these are like microcytes by any means, these red cells. But like a small lymphocyte should be around the same size. This is a relatively small lymphocyte. The red cells look a little smaller. You would identify this on a blood smear, on a CBC anyway. They're going to tell you about the MCV. Don't worry about that. Again, this is way too much info. You're going to come back to this for hemonc. But this is what microcytes are. If you see microcytes, they're small red blood cells. But it's really hard to identify from a smear. And then here's another lymphocyte. And then this would be a PMN, a SEG, a neutrophil, what have you. Here's a macrocyte. So macrocytes are really giant red cells. Again, really hard to tell from the smear. But what can always help you is if you have a hypersegmented neutrophil, which is what this is, a hyperseg. So this has more than 5 nuclei. Actually, it has 1, 2, 3, 4, 5. Yeah, so this has 6 nuclei. This is a hypersegmented neutrophil. So these cells will be, they're going to be a little bit bigger. Again, you're going to be telling from the CBC, the MCV is going to be big. So this is, again, going to be usually indicative of a B12 or folate deficiency, B12 or B9. But kind of like this hypersegs gives it away. And then this would be a lymphocyte. Again, the kind of like nucleus to cytoplasm ratio. Okay, so if you see hypochromia, this term, hypochromatic, anything like that, you're looking at the MCHC. Again, don't need to know that. But this is usually an indication of iron deficiency anemia. So iron deficiency anemia is a hypochromic microcytic anemia. So basically the red you don't have iron. You need iron to kind of make your red cells. So they're going to be really small, and you're going to have a really way more giant central pallor. It's going to be a lot. So hypochromic, the whole idea of this word is like it's less color. So it's not going to be as red because this central pallor is going to be expanded. So I put kind of over here your normal looking red cells with like with the central pallor you should see. And then this is like much more giant. And then here's a lymphocyte right here. Here are platelets. So platelet, 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 platelet. There's tons of platelets. But that's what's known by hypochromia. Okay, again, it's a indication of iron deficiency. Target cells. So here's something that they could kind of go into with your exam this year. So if you have your spleen out. So we'll talk about what target cells are. But I wanted to give you like all the different ways you could see what a target cell's name is. Another name of them is codocytes. No one calls them codocytes. I've never seen that. Usually people just refer to them as targets. So I see a lot of targets on this blood smear. And basically it's like the surface area to volume ratio gets completely out of whack. So how I kind of tell people to think about what a target cell is think about, so like your normal red cell, think about like you have like a needle and you're blowing into it and you're trying to inflate it with air. That's what like a target cell is. So it's kind of like, it's like reversed almost. Like it's not central pallor anymore. It's like a inner tube almost. Like now the center is like colored, but now the outside, it's like getting inflated on the outsides now. So it like goes out on the outsides. And it looks like a target. It literally looks like a target. You could use a bow and arrow to kind of get right in the middle. So instead of now seeing a clear space, that central pallor, now you're going to see like a little indentation. And that's why it's because the outside area is expanding. You're like, again, think of blowing into it with air and it's just expanding now on the outsides. That's a target cell. This is a lymphocyte here. So here's your lymphocyte. Here are platelets. These other tiny little gashes, these are platelets. So when you see target cells, and I tried to show you many images of target cells just because they all look kind of different. They always kind of look the same with the little indent. This is kind of an indication of an asplenic patient. There's obviously other indications to have target cells on your blood smear. They can also be kind of normal. It's not like a huge deal if you have target cells. But if you have an asplenic patient, this is like another this is something you would see on the blood smear. Like more often than not, almost all the red cells would look like target cells. Like here would be like a normal red cell. So this is like a normal red cell. So you can kind of see how different the normal red cell looks from the targets. This is actually really good. And so here's a normal one right here. And then here's a target. So you can kind of see like the difference. And the whole idea of like having your spleen out, why you have target cells, is because since this surface, remember I said how like the spleen takes out like misshapen or like weird looking red cells. This is a misshapen, weird looking red cell. So if you don't have your spleen out, if you don't have your spleen, you can't take out this weird looking red cell. So that's kind of the idea with asplenic patients having tons of target cells. Do target cells act differently than normal red cells? Technically they can. So you'll go into this more in hemonc. Technically they can actually carry more oxygen. Like technically, that's like the idea. They have like more surface area compared to the volume. That's why they look like they're about to burst. They're so inflated. But they really don't act differently. They really don't act differently than your normal red cells. In theory, they can carry more oxygen, but no, like not really. Like again, like you wouldn't worry if a patient had like increased target cells. You would just kind of be like, is something going on with your spleen? Or like what's going on there? But again, you'll go way into more depth about target cells next in hemonc. So are these cells normally removed by the spleen, or is there an increase in production rather than clearance? Great question. Normally, if you make a target cell, again, it's fine. It's normal to make some target cells, but usually these are removed by the spleen. So the spleen would see this and it would like pluck it out. So it's not like you're making more of these if you have your spleen out. It's just like the normal amount you make are not getting removed from the spleen. So they're kind of lasting in the periphery more than they should be. And that's kind of why you see like this whole like little window is all target cells, because clearly like this person has their spleen out, like they have not been able to remove them. Okay. Good on target cells. Spherocytes. So spherocytes, there's a hereditary condition that you guys will get in hemonc. Don't know this for your exam this year. They will not ask about this, but you will probably get a question on this next year in hemonc. So it's called hereditary spherocytosis. And basically the red cells don't have central pallor. So it's kind of like, remember I talked about hypochromia? It's like they're not as colorful with iron deficiency anemia. You can think of these as being hyperchromic, but hyperchromia is not a thing. So hyperchromia is not a thing. So they're like, let's call them spherocytes. So they just look like very perfect red little circles. No central pallor. Again, just like little circles. So that's spherocytosis. Again, you'll go into that more. The spleen in hereditary spherocytosis tries to remove these because, again, these are misshapen these are misshapen red cells. They're not supposed to be this tiny, and like they don't have a central pallor. So the spleen recognizes these as being bad. Well, not bad, but just recognizes them as being not normal red cells. So it will try to take these out. But if you have a hereditary condition where almost all of your red blood cells look like spherocytes, your spleen can actually enlarge because it's basically being overworked. It's like working overtime trying to remove every single red cell that you make. So you'll see with hereditary spherocytosis next year that these patients have splenomegaly, and that's why. So you can kind of draw it back to this discussion with immunology, where the spleen removes these misshapen red cells. And here's another picture of spherocytes, and then here's like a target cell. After splenectomy, do patients have to take certain medications to help against things like target cells? So something like a target cell, it's not that dangerous. Like it's fine. Like the red cell's still able to carry oxygen. So you really don't give the patient like anything to prevent against it because it's kind of benign. You're kind of more worried about like your encapsulated infections after a splenectomy. Also, we're going to talk about this like maybe in a little bit, but the spleen also takes out platelets. So if you have either your spleen's not working or you have your spleen out, you're gonna see a lot more platelets on your blood smear too, which is like fine, but it also could be, you'd rather like worry about the platelets than the target cells. Target cells are like basically benign. It's more of like just a sign that the patient's spleen is not working or they don't have a spleen. And like you can even see in this image here, this is a lot more platelets than you would normally see on like a normal like view of a peripheral blood smear. So it's like all kind of like coming together to help you figure out what's going on with the patient. But that's a good question. So target cells, again, kind of relatively benign. Even spherocytes are like kind of fine. The issue with spherocytes, again, is the spleen trying to remove these, and then it gets really big from trying to do it. Also, the whole point of having like the central pallor in your red cells is to carry oxygen effectively, right? It's that biconcave shape, so it can kind of like maneuver through the blood vessels. If you have spherocytes, they're tiny. There's no central pallor. They kind of look like basketballs versus like a biconcave shape. So these can actually get stuck in vessels. So spherocytes are a little bit more dangerous than target cells. But again, you just you do the best you can with helping the patient like kind of manage it. But that's so with spherocytes are, you'll go into this with hereditary spherocytosis and like how you kind of deal with a patient that has hereditary spherocytosis. But for now, I'm just kind of like bringing your attention to all of the things that could happen with the spleen, because that's like your immune organ. Does the spleen also get rid of old defected lymphocytes? I don't think so. I think the maybe? I'm not actually sure. Good question. You stumped me. I'm not sure. I know the spleen is like 100% for your old and defective red cells. I don't actually know what happens to the lymphocytes. Honestly, probably. It probably also does, but a lot of the pathology you see with the spleen coming out is about the red cells. That's a good question. I'm actually going to look that up after. Okay, next is your polychromatophilic cells. Everyone refers to these as polys or overall polychromasia. So the rule of thumb with this is whenever you see immature red blood cells on the smear, so polychromatophilic cells are basically immature red blood cells. Whenever you see immature red blood cells on the smear, it's kind of like I mentioned, like if you see an immature neutrophil, like a band, it's kind of like the body's attempt at being like, oh, we have a really bad infection, let's shoot out some immature like neutrophils, which are bands. With this, it's kind of like the same idea. Like if you see immature red cells on your blood smear, think of it as the body's way of trying to get this patient oxygen. So for whatever reason, it's like the red cells are not carrying oxygen effectively, or like something's going on where it's not enough oxygen, like they're not carrying enough. So it could be, maybe it's like, I don't know, but they're not carrying enough oxygen. So if you see these like blue looking cells, so polychromatophilic, it's like they're basically just like blue cells, which are here. These are just immature red cells. However, a little like peds plug is if you're a baby, what type of hemoglobin do you have as if you're a baby? Hemoglobin F. Hemoglobin F loves oxygen. It's like you are not taking my oxygen. It holds onto oxygen so super tightly because of that hemoglobin F. So you should actually see polychromatophilic cells on a baby's blood smear. Totally normal, because technically the hemoglobin F that makes up the red cells in the baby is not releasing the oxygen at the organs. So the body's like, all right, let me throw out some polys in this baby. So they're totally normal. Could kidney cancer also have polys if the tumor is secreting EPO? Interesting question. So EPO would make more red cells. No, you probably wouldn't see polys, right? So if the tumor cell's secreting EPO, you'd probably have more red cells. You probably have like the opposite of anemia. You'd have like more red cells. So you probably wouldn't see polys in that instance. This is more like if you have really bad iron deficiency anemia, if you have a hemolytic anemia, now we're going really into heme, but if you have a hemolytic anemia where like the red cells are just getting destroyed, that's when you would see like polys on the blood smear. It's kind of like the body's like, here, it's better than nothing. Here's like an immature red cell, since you can't carry, clearly you're not carrying oxygen effectively. But yeah, so it's like a compensation mechanism. Usually it's some sort of anemia. Again, this is not heme block. You're not learning the anemias, but just kind of wanted you to be aware of this. It's like a precursor for next year. And we're going to talk about another type of cell, which is the exact same cell. It just differs by the stain. Again, don't memorize these stains, but for next year, it's here for you. So if you use right stain, it stains ribosomal RNA. You better know that for boards, not for your exam. But right stain stains ribosomal RNA. So that's why this whole cell looks blue, because there's ribosomal RNA throughout this entire thing. If you use a different type of stain called a methylene blue stain, which also stains a different type of ribosomal RNA, it's going to look, it also stains ribosomal RNA, but it's a different stain, so it's going to look a little differently. Then you get what's known as reticulocytes, or retics, which you guys might have seen on your CBCs, maybe not, but they look like speckled red cells. So, but again, they have to tell you they use a special type of stain. So some of the inclusions we're going to talk about, people are like, how do you know the difference between this inclusion and a reticulocyte? Usually the inclusions you see without this special stain. If you use this special stain, like that's when you see the reticulocytes. So you kind of almost have to know that you're looking for this to see reticulocytes. Okay, so it's like a totally different stain from the normal stain. The normal stain is a right stain. So this would be like a normal, if you did a peripheral blood smear and used a right stain, it's not like a special stain for the polys. If you want to look at reticulocytes specifically, you would have to use like an additional stain on top of it. So it's kind of said here, literally it's like the exact same thing as a poly, but the stain is different. So again, immature red cell, bone marrow is trying to compensate against lack of oxygen in some way, shape, or form. They can be normal in adults, so they can be normal up until like 2.5%. Babies, hopefully this makes sense now, you should see the reference range is higher. And again, it's kind of the same exact reason as with polys. The hemoglobin F is holding onto the oxygen, so the bone marrow, and it's not like a pathology state. It's just like that's hemoglobin F. That's what it does. So this is how the body compensates when you're a baby. So if you have more than this 2.5% in your smear, clearly your organs need more oxygen. Unless you're a baby, then it's kind of normal. So again, think more like of anemia type thing. Okay, so these are nucleated red blood cells. I personally think these look very tricky to identify versus plasma cells. I think they look very similar to plasma cells. They even like stain, like they even look like the same color. So I think these are really, really hard. But another name for these are NRBCs. The way you can kind of differentiate these with the plasma cell is the very hypercondensed nucleus. So if we kind of look here at this nuclei, it's hard to explain, but kind of see how it looks a little bit more like it's crumbled together. It's okay if it doesn't, because it really does. It's just kind of like, it's hard to kind of tell the difference between these two. So you're gonna have to use like the vignette to help you identify. They'll never just show you this and be like, what is this? Unless they tell you this is a red cell. Unless they say this is a red cell, then you can be like, oh, okay, this is an NRBC. Because again, plasma cells are lymphocytes, or sorry, yeah, they're B cells. But these are very bad. These are like past, this is like, you know, the body's tried to shoot out the poly cells, tried to shoot out reticulocytes. This is like the body's like last ditch effort to shoot out like a very old, like very immature version of a red cell to carry oxygen. So this is like, this patient is starving for oxygen if you see an NRBC on the blood smear. Again, it's completely abnormal even if you see one. So the real reference range is literally 0. Here's like, I think this is a good idea, like image of seeing like the hypercondensed nucleus. But I tried to show as many possible pictures that I could of like what an NRBC looks like. Here are NRBCs here with the arrows. This is a lymphocyte here. This would be like a polychromatophilic cell. It's gonna kind of tell a story that this patient is like very, very starved for oxygen. Like you should see like polys here and there. You should see some other cells before you see like an NRBC, but they're very, very bad. Okay, here's your next one that you should know for your exam this year. So these are called How Jolly bodies, which hilarious name. So How Jolly, it's just like a single dot kind of on like the periphery of the red cell. Okay, and again, this is not like a special stain or anything. This is like your normal stain, like your normal right stain for a peripheral blood smear. And it just looks like a dot. Here it is, here's the dot. And again, if you notice here, these are target cells, target cell, target cell, target cell. These are all target cells. Some of them have dots, some of them don't have dots. Some of the target cells don't have dots. This one isn't a target, but still has a dot. So these are what How Jolly bodies are. You should know what the inclusion is. Like, what is this dot? It's DNA. So it's basically just DNA. And this you see in asplenic patients as well. So remember, again, asplenic patients, well, the spleen removes deformed or like weird looking red cells. This type of thing, the spleen would take this out. It would just kind of like literally chomp and remove it. And then they would look normal. But if you don't have a spleen, you're going to see How Jolly bodies. You're going to see target cells. You're going to see all sorts of things. You're going to see increased platelets. Like you're going to see all sorts of things when you don't have your spleen. Okay, so this is like another thing if you're doing a vignette and it says patient has target cells and How Jolly bodies seen on blood smear. Asplenia. Start kind of thinking of asplenia. This is just kind of like a term. You might see this when you're doing, so I just kind of wanted you to be aware of it. Poikilocytosis, ridiculous name. But it basically means like all of the red cells are different sizes. So it could even be so much as like some are big, some are small. Like this one, some look like teardrops. Like some are just like weird looking, some are big, some are small. Or it could be like they really just all look super strange and weird. These are both examples of poikilocytosis. It just means the red cells are misshapen. Here are your platelets. Like I kind of said, so this is your normal reference range for platelets. I'm sure you guys know this from doing case with CBCs and whatnot. But again, this could be fair game for your exam this year, right? Because again, you need your spleen to remove platelets. So again, this is kind of like seeing a lot of, this is way more platelets than you would see. All of these are platelets, like literally all of these pink circles are platelets. So this would be like, again, an asplenic patient. So someone that can't remove all these additional platelets would be asplenic, or there's like platelet disorders where you just make more platelets. That's next year. That's again going to be a hemonc thing. But if it's not one of those disorders where you're making more platelets, think like asplenia again. So again, if you're seeing target cells, you're seeing How Jolly bodies, you're seeing elevated platelets, again, asplenia, or like the spleen's not working or something's wrong with the spleen. Okay. That was your brief heme intro. So I have questions for that before we go to vaccines. But do you guys have any last minute questions about that. Cool. And if you do, you can just chat, but let's do the first one. Yeah, no, I'm sorry. I didn't give you guys options. I realized I probably should have. Um, and yeah, platelets do kind of look like spherocytes, right? Like they're really tiny. It's just like they're gonna be even smaller than spherocytes. They're like literally just pieces of like a cell right here. Like they're just like pieces of a cell cytoplasm that like broke off. Spherocytes are gonna be like probably like that big, so a little bit bigger. Okay. A lot of you guys answered. So these are target cells. Awesome. Some of you guys said microcytic. That's fine. Like they technically are microcytic, right? Like they are smaller cells. But I was kind of trying to get, that's why I probably should have put options. But like these are clearly target cells. You see like it's almost like the opposite of a central pallor. Like let me see if I can find a normal. This is the most normal looking red cell. And see how it looks like exactly opposite from your target right here. So that's good. Yeah, so these are mostly target cells. This, good question. I would say this would be like an eosinophil maybe. I don't know. This is hard. I mean, the pink granules are big. I would probably see if this patient had more like eosinophils throughout its peripheral blood smear before definitely calling this an eosinophil. But the granules are really big, and this is relatively pink, so I would probably call that an eosinophil. Okay, next. Okay, that's coming up to like a minute and a half. So what does this patient have? You guys didn't pick up on that. They probably would have told you first year what this patient has. Yes, very good. This is mono. This is classically how mono presents. Cervical lymphadenopathy, fatigue, sore throat, fever, too tired to go to class, like all that. This is mono in like a 19-year-old. So with mono, remember I told you there's two types of cells you really need to remember with mono. Epstein-Barr, and we're going to talk about this on Thursday because that's one of the ones that Dr. Milani wanted me to go over in terms of micro. So one of them is your CD8 positive T cells, and then the other one is B cells. So these are the two cell types you should kind of associate with mono. So for CD8 positive T cells, these are your reactive lymphocytes. This guy. So that's why this answer is B. This is cytotoxic T cell. Dr. Ryan on Boards and Beyond made it harder. He didn't give you CD8. He gave you the other name for cytotoxic T cell. Another name for CD8 positive T cell, cytotoxic. Some of you guys picked CD4, totally fine. A lot of you guys were like, I know it's one of the T cells. Very good. So this is going to be your reactive lymphocyte is a CD8 positive T cell. Okay. The other cell to keep in mind, so good, none of you guys picked B cells. The other thing with mono is mono remains dormant in your B cells. And this is something we're going to talk about on Thursday. But a lot of the times they're trying to get people to say that these are B cells. They're like, oh, well, they're dormant in B cells. It's freaking the B cell out. It's causing it to get bigger. No, it's your cytotoxic. It's like they're reacting to the virus, right? And what cells do you need to get rid of viruses? Cytotoxic T cells. So they're reacting. They're like, nah. And they like get bigger and crazy. Like they look like angry lymphocytes. So that's your cytotoxic T cells. One of you guys was like, oh, I would have said monocyte if it's an option. Perfect. This looks like a monocyte. So that's kind of like another way to like be like, oh, this looks like a monocyte. It's not an option. Oh, maybe it's a reactive lymphocyte, right? Because I think reactive lymphocytes look just like monocytes, personally. Just a weird like looking nucleus though. So that can be like another indication like, oh, let me go back and read and make sure they're not talking about mono and this is a reactive lymphocyte. Okay? But we'll talk more about mono on Thursday. I kind of went over, I'm going to go over what she had wanted me to go over. But just keep this in mind, like these two types of cells with mono in mind, and you'll be golden. And just remember that the CD8 positive one is the reactive one. It's the angry one. It's trying to fight off the virus, like CD8, like cytotoxic T cells do. Okay. Here's this. I'll obviously have this posted, send it out. Okay. Next. All of your guys' answers are like right. This is my issue. This is my issue with not putting options. But you guys are doing great. All of the answers have been correct. Okay, anyone else want to say what you would run? All right. So good. Some of you guys are like, oh, this is a hypersegmented cell. Absolutely. This is a hypersegmented neutrophil. Lots of lobes to the nucleus. Again, you don't really even have to count, but you can just tell that this looks like an odd neutrophil. Good. So this you would want to run a vitamin B12 and a B9. So folate and vitamin B12. Remember that you see hypersegs most commonly in like your megaloblastic anemias, your just giant looking anemias where the cells are really, really big. And if you see hypersegs, that's another indication of it. Okay, so that's more of like it was a tie-in with GI because you did do B12 and B9, but you will go into megaloblastic anemias and stuff next year. Cool, very good. All right. Okay, let's talk about this one. So I gave you guys a little hint. I underlined RBC because that's really the only way you can differentiate this. But this is a nucleated red cell, so an NRBC. One of you guys said bad. Very good. This is very bad if you see this. Again, if you were like, I really don't know if this is an NRBC or a plasma cell, they didn't tell me in the prompt. Sorry. Kind of look for like the perinuclear halo. It's going to be very obvious that there's not like this does not show a perinuclear halo. The perinuclear halo is like a little bit wider out. It's not just like surrounding the cytoplasm. But usually they're gonna like it's gonna be like they'll tell you something to tell you that it's an NRBC. But yeah, if you're looking and you're like that looks like a plasma cell, but you're like wait it's a red blood cell, it's gonna be an NRBC. Okay, very bad. All right. Yeah, so these. Okay, let's go over this one. Guys are all over the place. I love it though, because again, you just did this today for the first time. So one of you guys said macrocytes. Very good. These are giant cells. That should be your first indication. These are very, very big cells. Some of you guys said spherocytes. Spherocytes are very tiny. They're very, very, very tiny cells. So that's going to kind of be, if you're between like two, the spherocytes are really small. So these are really big. These are kind of different colors, right? Like you can even see with the rest of the smear, like these are all looking red. These look a little blue or at least purple. They look a little different in color. So these are going to be your polys. So your polychromatophilic cells are going to be big. They're going to be like they don't have to be like full on blue, but they're going to be more blue than like the rest of the red cells in the smear. And then some of you guys said how jollies. So I'm glad then that I asked this. So I think you're referring to this dot here. This is not a how jolly dot. So a how jolly dot is going to be like blue. It's going to be blue. And one of you guys are like, I think it's a how jolly, but it's not the same color. And that's exactly like it has to kind of be that color. Let me see if I can find. Yeah. So this straight up is what it's going to look like on a smear. It's going to be blue. It's not going to be like it's not going to be white, a white circle like this. This is not a how jolly. These are just circles in the red cells. But how jollies are these big dark blue, like these big dark blue inclusions within the red cells. Okay, those are how jollies. So those are polys. Those are like a little bit bigger in size. They're like purplish, bluish. Okay. Yeah, I would say this is a lymphocyte. Yep. Again, it's kind of weird looking, but again, the cytoplasm, the nuclear to cytoplasmic ratio always gives it away. Okay, what about the blue arrows? So these. Okay. Let's go over this one. So these are your spherocytes, okay? So I'm glad I kind of have like a side-by-side comparison with the normal cells. So this is like a normal red blood cell, a spherocyte, and a polychromatophilic cell. So you can kind of see like how they all like differ. Spherocytes, they're tiny. One of you guys were like, oh, they're the hyper, like the super colored ones. Exactly. There's no central pallor. They're dark red little tiny circles. Those are your spherocytes. Okay. Cool, very good. Last one. Sorry, this one. Oh, well. Okay, I'll give you guys a few more seconds. Okay, so this is the one that I put on here multiple times because this was on my exam. This is an eosinophil. So again, the bright pink granules, the lobes, I know, they're hard to differentiate between a neutrophil, especially if a neutrophil is not in the same slide, but it's just going to look pink. It's just going to look more pink. But a lot of the times, like I said, they're going to give you a little vignette. And it's going to be like something about allergies or a parasite infection or a helminth, like a worm infection. But they do just look more pink compared to neutrophil cytoplasm. And the granules are a little bit bigger. And yes, these are platelets around here. These are all platelets. But good. Awesome. You guys are hematologists. Do you guys want to take like a 5-minute break? I keep promising a 5-minute break and then we never do it. All right, let's do a 5-minute break. Oh, some of you guys are like, yes, no, yes, no. It's okay. Multiple people said no at the same time, but a lot of people said yes. All right, let's do it like we'll do like a 4-minute break. Let me pause. Okay, so I've unpaused, I think. Yes. All right. All right, so we're moving on now to vaccination. So vaccination, it's basically nothing new, which is nice. I mean, there's a little bit about the types of vaccines you will have to know, but basically vaccines in general are a combination of B-cell stuff and T-cell stuff, which is pretty cool. You can kind of see it all play together. And then at the end, actually, do I do? No, I don't. But at the very end, we're going to talk about types of vaccines, and that's kind of important. And what I mean by that is like you have the MMR vaccine. What type of vaccine is that? And it's because it does different, like there's like different principles behind it. So we'll talk about that at the end. Okay, so here are some principles behind vaccines. We have to talk about epitopes. You have to know about memory cells. So we have to go back to B-cell activation and T-cell activation. Here's actually something a little bit new. So haptens versus adjuvants, and then primary and secondary immune responses, and then original antigenic sin. So this is kind of like an outline of what we're going to talk about. This is straight up what we talked about in B-cell activation, T-cell activation, and there's just a little bit of new info. Okay, so with this, like the B-cell receptor and the T-cell receptor, remember that B-cell receptors and T-cell receptors only see portions of an antigen. They don't see the entire antigen. And that's what's known as the epitope, right? So if we look at the T-cell receptor, which is down here, alpha beta, it has a paratope, which I don't actually think I think it is actually. The paratope is on the receptor. So it's going to be like this little like actual parts in the blue. And that's what's recognizing the epitope, which is on the antigen. Same thing with the antibody or the B-cell receptor, whatever. So here's antibody 1, as it says, the FAB portion. So imagine that this is like, it's just not drawn completely, but imagine this is like one FAB portion, here's another one over here, and then here's your FC, and kind of the same idea, FAB, and FC. But anyway, the FAB portion, specifically the paratope on the FAB portion, is what's recognizing the epitope on the antigen. So you can have different antibodies recognizing different epitopes, all a part of the same antigen. So that's kind of where this idea of like understanding like epitope versus like paratope kind of comes into play. But this is really important to understand for vaccines, is that you're really, like when you have T cell receptors, B cell receptors, they're only recognizing portions of an antigen, not the entire thing. So here's kind of like your review of B cell activation. So when the B cell acts as an antigen presenting cell, it's going to go find an already active T cell. So this is not a T0 cell. This is a CD4 positive T cell. And then it's going to get activated. And then once it gets activated, you get, again, we're talking about T dependent. So you're going to get memory and you're going to get plasma cells. So remember, now it kind of makes sense. Like, oh, here's the perinuclear halo, right? So here's kind of the perinuclear halo that I drew in the white. And these are like your antibody secreting factories. And memory cells are literally like copy and pasted versions of this B cell that we just activated, and it found an activated T cell. That's what's known as clonal expansion. We found this one B cell and now we're expanding it, but we're making like little clones of it. That's like the idea of clonal expansion, is making like these little memory cells from it. And this antibody is the exact one we just made. And this is even after, somatic hypermutation, affinity maturation, class switching. It's really just like saving this. It's like the body's like, let me just store this for later. Those are your memory cells. So this is kind of what, I don't know if we went into this much detail. I just kind of mentioned, like, oh yeah, somatic hypermutation, affinity maturation, whatever. But when you activate a B cell, like let's say we have a B cell acting as an antigen presenting cell, it's in the germinal center. And then what's going to happen here? So like, here's kind of where we started from. So here's our B cell. So we're in the germinal center here. So we're in like the secondary lymphoid tissue. Here's your B cell. It's going to interact with some sort of like a dendritic cell, something that's going to present antigen to it. So one of the types of cells that can do this is a dendritic cell. It's presenting antigen to it. So here it's getting antigen presented. Now we're going to go through T-dependent B cell activation. So T-dependent B cell activation. Remember, I kind of mentioned in the T cell lecture, if you're in the germinal center, like if you're already in that secondary lymphoid tissue, it's usually going to be a follicular helper T cell. That's what TFH is. This is the one that's helping with somatic hypermutation and affinity maturation. So from here, basically what happens is it gets activated. You can make memory cells, you can make plasma cells, and then you can also kind of go back through this process and like make a much better fitting B cell receptor to that antigen. And that's kind of what like somatic hypermutation is. It's like little tiny mutations that make the FAB portion recognize that antigen even stronger. And it kind of cycles through this process. That's what somatic hypermutation is. I don't know if you guys remember, but on when I did the B cell lecture, I was like, oh, it kind of goes back and forth between like the follicular helper T cell. It goes back and forth. That's basically what it's doing. It's like cycling through. It's like how does it fit now? Like when it comes back here, it's like, how does it fit now? It's like, okay, cool, let me expand that. And then it's like, oh, let me make it even better. And it goes through this process again. It's like, okay, how does it fit now? And that's kind of what like somatic hypermutation is. It's just making it a little bit better. And yeah, I'm going to refer to it as the CP antigen. So like, that's just like, yeah, I just named an antigen after myself. It's fine. But like, if I'm referring to like just a random foreign antigen, like throughout the rest of the sessions, it's going to just be the C. So this is just like a random foreign antigen. Okay. So yeah, memory cell, plasma cell, and then it can kind of go back through the cycle again with somatic hypermutation. It's kind of like it goes back and it samples the antigen again, and then it goes back to the follicular helper T cell. It's like, how's it fit now? Okay, let me go back. And that's somatic hypermutation. Okay. T cell activation is kind of like, all right, here's an APC, and there's no signal 2 on here, so shame on this image, right? But anyway, so we have an antigen presenting cell, and it's going to present antigen to a naive T cell. We get signal 1, signal 2, and then it kind of tells it like, all right, what type of T cell do I want you to become? And at the end of the day, you get memory. So that's what I wrote here. Don't really know the difference between central and effector memory T cells, but what I wanted you to see from here is you're getting memory T cells from this process, and you're also getting effector T cells. And this could be If you want it to be CD4 positive T cell, this could be like a Th1 would be the effector T cell, Th2, Th17, TFH. This is whatever T cell you're trying to make. It can also be a CD8 positive T cell. Whatever T cell you're trying to make, that's the effector T cell. So you're also getting memory. So you're getting memory T cells and you're getting whatever effector T cell. Okay, so this is kind of what I just wanted you to kind of see from this image is we're also getting both. Just like with B cells, we're getting memory and plasma cells. With T cell activation, every single time we make T cells with this signal 1, signal 2 thing, we're also going to get memory. So here is, so this, let's say this is the APC presenting the CP antigen, and it's going to give it IL-6 and IL-21 to this naive T cell. So this would be like your T0 cell. So this T cell just got activated by the same antigen that got activated by the B cell in the germinal center. So let's say this CP antigen is floating around, an antigen presenting cell picks it up and it presents it to like a naive T cell. This is the same antigen that this dendritic cell presented to the B cell in the follicle. It's still the CP antigen. So what you're kind of seeing, like what I'm trying to build to, is like we're presenting the T cells and the B cells with the exact same antigen, okay? And then from here, all right, we want more follicular helper T cells, whatever. You can make whatever T cell you want right here. But in this example, if we're making more follicular helper T cells, we're going to go, the whole point of them is to go activate more B cells. So then this guy would go back to the germinal center, and it would be this guy right here, okay? So why I'm kind of emphasizing this idea of like the B cell getting activated and the T cell getting activated by the same antigen is because you're making what's known as a conjugate pair. So a conjugate pair is basically when the T cell that gets activated by the CP antigen all on its own, and then the B cell got activated by the CP antigen all on its own. Now they're going to come together and you're going to get this really super strong response. This is your conjugate pair. We talked about how B cells can get activated by T cells anyway. That's not really a conjugate pair. A conjugate pair is when like the T cell got, like this is an activated T cell, right? This is a follicular helper T cell. So this got activated by CP antigen on its own. This got activated by CP antigen on its own. And now they're coming together, and that's your conjugate pair. This is what you're trying to do with vaccines. This is exactly what we're trying to do. We're trying to give vaccines that both T cells can recognize and that B cells can recognize all on their own so that they can come together and you get such a really big, strong immune response. And you'll kind of see, okay, yes. So this is what every vaccine is trying to do. And you'll see, I'll go into a little bit more detail so you can visualize it. Another name of like a conjugate pair is a cognate interaction. I just can't really say that, but it's the same terminology. So cognate, maybe it's cognate, a cognate interaction. And so it's like a cognate interaction and conjugate pairs. The conjugate pairs are having a cognate interaction. It's just silly terminology, but it's the same thing. A cognate interaction means that we have a conjugate pair, basically. So this is saying like, okay, here's CD4 T cells are activated by, let's say, the CP antigen, right? They're going to go to the follicle. The B cells are activated by the exact same antigen. So when they come together, which is right here, so the B cells are in yellow and the T cells are in blue. So when they come together, they're going to make this cognate interaction. This is going to be a conjugate pair. And this is what's going to be a really, really nice, strong reaction. Okay. Okay, so we'll come back to that, but I kind of wanted to talk about this because they might ask about, they asked about this last year. So haptens. So you might see this with vaccines, this terminology of a hapten. So a hapten is a small molecule that does not elicit an immune response by itself. So a hapten is not immunogenic. So remember I said if you elicit an immune response, you're immunogenic. So a hapten is not immunogenic basically only because they're not big enough. They're really, really, really tiny. So they're not even big enough to make an immune reaction. The immune system kind of just like overlooks them. They're like, all right, you're really small. I don't really care about you. But what you can do is you can conjugate, so you can attach a hapten to a giant carrier protein, like just a giant protein. So now you're increasing the size of this overall pair. Now the immune system can see it. Now you're making it immunogenic. And again, the carrier has to be a protein. At this point, I hope you guys realize like it should always be a protein. So you activate B cells T dependently. But when you do this, when you conjugate a protein to a hapten, you get 3 types of antibodies. So let's say we conjugate this protein to this hapten, we inject it in someone, you're going to see 3 types of antibodies. You're going to see an antibody just to the hapten, you're going to see an antibody just to the protein carrier, and then you're going to see antibodies that are going to recognize both the hapten and the protein carrier. And again, this is just because of the whole idea of like when antibodies are binding to antigens, they're only recognizing epitopes. So some antibodies are only recognizing epitopes on the hapten, some are recognizing epitopes on the carrier, and then some are recognizing epitopes on both. Okay, so here's kind of like a picture. So the hapten is this tiny little triangle, and now we're going to conjugate it to a carrier protein. So we're going to basically just attach them. We're going to inject it into a rabbit, and then from here, you're going to make antibodies to the hapten, so only antibodies that recognize hapten, antibodies to the carrier, so only to this blue protein part, and then antibodies that recognize both. So we're doing hypersensitivities tomorrow. This concept of haptens becomes really, really important with hypersensitivity reactions because there's a specific type of hypersensitivity you get after vaccination. And this is kind of why you kind of get like these antibody responses to these haptens. Okay. But we'll talk about that tomorrow. So those are haptens. You get 3 types when you inject them. Okay. Next are adjuvants. So adjuvants, these are anything that is added to a vaccine that just like further pisses off the immune system. So adjuvants are not like, they're really just like chloride or they're aluminum. Like they're just like metals and stuff. The only purpose of you adding them to vaccines is to just really annoy your immune system. So I say think of adjuvants as the annoying siblings that try to annoy you so much to the point where you just get up, get mad, and go chase them around the house. That's like what an adjuvant is trying to do. So the adjuvant is added to the vaccines, and then you in this scenario right here is the immune system after the vaccination. You're trying to elicit a really intense immune response. And again, when we talk about the types of vaccines at the end of this, we'll talk about adjuvants. But a lot of the times with like, you know, when you guys got like your COVID vaccine and some of you guys were like really sick after the second day, that's good. You kind of wanted to be like after the second shot, you kind of really wanted to get sick because that means you have made such a really intense immune response. Sometimes that can happen after the first time you get a vaccine, and that's because of these adjuvants. They're just things you're specifically trying to add to annoy the immune system to get it activated and ready to go. Okay, so then this is kind of like the primary versus secondary immune response. This is like really, really important. So we have to talk about this. So the y-axis is concentration of antibody. The x-axis is time. And then this is where we get the first exposure of the vaccine, let's say. So this is your initial exposure of your vaccine. Let's say this is the first time we ever saw this antigen. So the first time we ever saw this antigen get injected. It's going to take about like 7 to 10 days to even get like antibodies. And why? B cell activation. It doesn't happen overnight. We need inflammation, right? First, we go through the innate immune response. First, we try to do inflammation. We try to do complement. We try to do all that. And then we're like, oh, let's activate B cells. We need B cell activation. We need to get the adaptive immune response involved. So this takes a really kind of a long time to even generate this small amount of antibody. But then a little bit later, that second time you see that same antigen, now you get this intensely high antibody concentration, super high, and look how quickly it took to get there. Super quick and super strong secondary immune response. That's known as the anamnestic response. Okay, so primary immune response takes about 7 to 10 days. You don't get that many antibodies produced from it. And again, it's because you have to go through the innate immune system, and then you have to go through B cell activation. You have to activate the B cells to release antibodies. It takes time. It takes about 7 to 10 days to do all of that. And then after that secondary exposure, the second time you see the same antigen as you saw right here, the body's ready. It's like, oh, okay, like I saw this already. I have my memory cells. I have my effector cells. Like I'm ready to, like I can react right away. So you react super quickly. It's like a 1 day period. And then you make so many antibodies after this point. And again, this is kind of the whole idea behind booster doses. This is kind of like the whole idea why they say you're not fully vaccinated until 2 weeks after your second shot. And this is kind of why you're kind of like giving your immune system time to go through this secondary response. Okay, so this is a really important concept. Okay. So the primary response is, I kind of put these here from the pictures we talked about last week. So the primary response, think of this as like getting an infection naturally. So again, we have to go through B cell activation, we have to go through T cell activation, and remember that takes a little bit of time to get to. So we need to go through B cell activation to make memory cells and plasma cells, and then we need to go through T cell activation to make effector T cells and memory T cells. So again, takes a little bit of time to do all of this. Your body just doesn't have this, it has to go through that whole process. But the second time you see that same antigen, again, it's kind of like getting the same infection again later, you don't need to go through these again. We don't need to go through B cell activation and make more memory cells and plasma. We already have memory cells, right? Like we don't need to do that. And that's kind of the same idea with T cells. We don't need to do this again. So that's why it's saying you can basically skip these 2 steps and just start immediately. So we're basically like ruling this out. So for example, this highlighted in purple, this is what the body's going through the primary response. And the secondary response, this is all the body's going through. So again, it's really, really quick. And again, this is a whole idea behind booster doses and the whole idea behind vaccines in general is so like when you actually see the pathogen, you can just start, like you can just fight it off immediately. That's why some of you guys, like probably all of us have been exposed to measles at some point, but if you're vaccinated against, you don't even know that you have an infection because it's like you already have the memory cells. Okay. So here's another kind of image of this. So pretend that this is a T-dependent antigen. So here's B cell activation. So we have production of antibodies. And then the second time we see that same antigen, because we don't want the B cell to undergo the whole process all over again, we just want the memory cells with the high affinity, and you get high affinity IgG being produced at a later date. So this is kind of like another, just kind of adding to this graph. The first primary response is going to be IgM, because again, it's the first time you're seeing something. And remember, I always said like acute infection, think IgM, and think of the primary immune response as being like an acute infection. Okay, so IgM, like low specificity. Again, it's like, okay, let's just try to activate complement maybe. Low antibodies produced in general, takes a really long time. The secondary response, we have high affinity IgG being produced. We have tons of antibody being produced, and it happens really pretty quickly. Okay, so sorry, I hate putting a lot of words on the slide, but just to kind of really hammer this home, vaccines are basically trying to show your body a specific pathogen, but in a controlled manner that won't kill you. So when you actually encounter the pathogen like naturally later in life, you already have memory cells ready to go to fight it immediately. So commonly what happens with vaccines is you use epitopes that typically do not change, because if they did change, the pathogen will be less pathogenic. So what I mean by this, so before I kind of go on to this, is a good example is I used the flu here, but a good example would be something like COVID. So we use the spike protein with COVID because that's how COVID enters our cells. So if let's say COVID was trying to be smart and it's like, well, let me just change my spike protein because everyone's vaccinated against it. If it did that, it can't enter cells, it can't survive. So that's why they use epitopes in vaccines, that if the virus tried to change its epitope, it just wouldn't survive. So those are the ones that are really, really good to use in vaccines, because if they tried to change it, it would be less pathogenic. And you can kind of see it kind of happened with COVID, right? We went from a really super pathogenic variant with alpha, and now we're on like Omicron, or I don't even know what we're on anymore. We're on like the B1 variant. Not as pathogenic as alpha because it started to change because of the vaccine. It was like, let's change a little bit, but now it's less pathogenic. But a downfall to this is that not all pathogens have constant epitopes that can be targeted. And we'll go through, I think on Thursday, some examples of this, like why there aren't vaccines to every single virus. And another downfall is what's known as the original antigenic sin. This is really common in the flu virus. This is kind of why we have to get the flu vaccine every single year, because of this idea of the original antigenic sin. So, okay. So we're going to talk about this first. So, okay. So this is what I was mentioning. So this is COVID, right? So it's a virus. It's non-living. It has no organelles, but it has these spike proteins on its surface. And the receptor that it uses to bind in our body is the ACE2 receptor, which is in the lungs. Okay. So here's COVID, here's ACE2 in the lungs. When COVID binds to it, it is a perfect match. Look how beautiful that is. So now it's able to bind, and now it's able to enter our cells. And that's how it replicates, that's how it survives, and so forth and so on. Let's say COVID. So a feature of RNA viruses is that they just randomly mutate. Again, we're going to talk about this on Thursday about like RNA viruses, like how they randomly mutate. But it's just like a random thing that RNA viruses do. They don't have a polymerase that can proofread, so you just get random mutations. So let's say we have a variant that has a different spike protein now because of this mutation. It tries to bind to its receptor. It can't bind to it because the spike protein is not a perfect match to it. So now it tries to bind to the receptor. It dies. It can't live on its own. It needs cells to be able to replicate and to reproduce and stuff. So that's why the spike protein with COVID is a really, really good target, like a really good epitope to use in the vaccine. Because if COVID tried to mutate around it, then it can't enter the cells. It's going to die. So again, oh my God, I'm saying everything. I get too excited about vaccines. But the spike protein was a great antigen for it because, again, can't bind, it dies. And a lot of the times with certain vaccines, spike protein vaccines are very, very common. So with the flu virus, we use spike proteins with the flu virus. With smallpox, when smallpox was a thing, they used the spike protein with smallpox. Okay, and then the second part is this idea of original antigenic sin, specifically with the influenza virus. So we're going to talk about this. So here's like a dumbed down version of like the primary and secondary response. So here is kind of like your pathogen. Imagine your pathogen as a ghost wearing a white sheet. So the only thing that your immune system can see is this white sheet. That's all it can see. So it comes into the body, the immune system coordinators, which we now know is like the innate immune response. We know it's these sentinel cells, right? Your epithelial cells, your dendritic cells, macrophages, your sentinel cells see this. And it's like, oh, let's coordinate an immune response to this. So they're going to tell everyone, like all the other immune cells, like, hey, attack anything you see that has a white sheet on, okay? So the soldiers are like, all right, cool, let's do that. So it takes some time. So it's going to take some time. It takes about 7 to 10 days, right? But effectively, you will get rid of this pathogen. And that any time you see a white sheet in the future, you're going to be ready immediately to kill it. You don't have to go through like this whole process again. Now, the second time you see that white sheet, these guys are ready. They're like, oh, okay, I know what to do. I can kill it. So it immediately kills it. But let's say there's mutation. So RNA viruses have very high mutation rate, something like COVID. Influenza is an RNA virus, high mutation rate. So let's say instead of having a white sheet, now it has a red sheet. So this ghost now has a red sheet. So the immune system soldiers, right, they see it and they're like, I've never seen this red sheet before. Like, do I attack it? What do I do? And this is kind of this whole like little process right here is kind of the idea behind antigenic drift. Okay. So antigenic drift, and this is terminology you should 100% know. Here's COVID, all right, so this is the flu. So this is flu, and they have white like spike proteins on its surface. Think of this as like the white sheet. Then there's some mutations that happen, and now the spike proteins, they look like they're red. So now think of this as like the red sheet. This is a variant of these white spikes. So it's the same virus. You see, it's the same DNA. The DNA did not really change at all. It's just now there's red spike proteins versus white spike proteins. This is known as antigenic drift. So antigenic, the antigen that our immune system made a response against, it's now drifting away to like a different type of antigen. And it's drift because it's happening, it's like a drift is like it happens based on mutation. So there's like little mutations that happen that make it drift away to like almost like a different antigen now. So that's antigenic drift. Antigenic shift is now we're shifting. We are like massively shifting. We have a totally different like strain now. So this drift, think variant. Shift, think strain. So like think like a new strain, a new species, a new whatever. So with antigenic shift, this is when, let's say we have flu virus 1 that has white spikes, enters like a bat or some sort of animal with flu virus with red spikes. So this would be like a variant, right, of the white spike one. So we have two different like types of viruses, right, entering a bat. Then they undergo what's known as a recombination event. So it's not mutations, it's recombination. Like the DNA is literally changing between these two viruses. And now we have a totally, totally different flu species that we've never, ever seen before in our entire lives. That shift, we're making a new species. It requires two different viruses to recombine within some sort of animal. So I gave you a bat here, but remember swine flu in like, I forget when swine flu was, but like 2000 something? This was a pig, swine flu, swine, pig. So this is what happened. You had two different flu viruses that recombined in a pig, and we made a new flu virus, and that's swine flu. Okay, so it happens. It does happen. And then the last important thing is to understand that drift, this is why we need flu shots every year. Shift is why you get pandemics. So drift, think like epidemic. So again, like every year that there's flu outbreaks, that's a flu epidemic, right? So epidemic, it's contained to a certain area. It's not like a global scale. It's just like, oh, the flu's going around. That's an epidemic, right? So think epidemics with this. Shift, this is your pandemics. These are a lot less common, obviously, but clearly they happen. This is how they think that COVID happened. They think that COVID happened with two coronaviruses that recombined, and then we made an entirely new coronavirus. So again, small mutation. So it's like the DNA is going to be exactly the same. It's still purple, but now it looks a little bit different. Versus like we have purple, green, yellow, and now we have a totally new strain that has like features of all of the viruses that recombined. Okay, so that's like swine flu, that's COVID, well, what they think happened with COVID. Okay, and then there's this idea of original antigenic sin. So original antigenic sin is kind of like, it's like the immune system trying to fight off the virus, but it actually ends up hurting us. So what I mean by this is kind of like an involved chart, but let me kind of show you what's going on here. So this is your primary infection, the first time you see the flu virus. So let's say the first time you see the flu virus, it has 4 different epitopes on its surface. So let's just say there's 4 different epitopes. And remember, like I said, when you're responding to a pathogen, you don't have to, like, depending on what part of the antigen you're seeing, you might only make antibodies against one of the epitopes. It's whatever the paratope is binding to is kind of what you're making antibodies against. Because again, you're not seeing the whole antigen, you're seeing epitopes of the antigen. So think of this as being like epitope A, epitope B, epitope C, epitope D. Okay? So this is the first time we see the infection. Let's say it knocks us out for 14 days. Okay? Because again, it takes a really long time to kind of go through that whole process. And when you do it, you're making like not great specificity. This is kind of saying like, okay, we're making like half specificity antibodies. Usually it's just going to be IgM, but at least you're making them to A, B, C, and D. So in this example, we made antibodies against all 4 epitopes. So you're like, okay, that's cool. That's great. So the next time you see it, let's say, and this is kind of what happens only with the flu virus, because the flu virus just has tons of epitopes. Let's say this second flu virus has A, B, C, and E. So no D. This is like the next year with the next flu season, right? So instead of having A, B, C, D, it has A, B, C, E. Well, the year before, we saw A, B, and C, right? Like we saw them already. So memory kicks in. Memory is like, oh, I saw A, I saw B, I saw C. So you're going to go through the memory response. You're going to go through that secondary anamnestic response with A, B, and C. But note here, the body almost like preferentially chose to use A, B, and C, the memory that it developed a year before, against A, B, and C. You made no primary response. You made no primary response against E. It's like it preferentially was like, let me just use memory. I made memory last year. I mean, that's the point of memory, right? Like that's a good thing. Like, isn't that a good thing? Like, hey, we made memory last year. Why wouldn't I just use it? But you don't make anything against E. You make absolutely no. You don't even go through a primary immune response against it. You don't even get low affinity E because the body's just like, too much work. I want to use my memory for A, B, and C, which is fine. you're not even sick, days in bed, one day. Like, you're not even sick from it. You, like, completely, like, your body completely takes care of it. It's like, we're fine. But now we start getting drift. So we're starting to drift away a little bit. So now instead of having A, B, C, and E, we have A, B, E, and F. So it's like, okay, you know what? We made memory 2 years ago with A, B, C, and D. We made memory. Let's just use memory again. Let's just use memory. It's fine. Whatever. Let's just use it. You're not clearing it out as quickly because now there's these 2 epitopes that the body has never even made memory against once. But it's like, you know what? You're fine because the body made memory against epitope A, epitope B, like high affinity IgG. You get rid of the virus. Now we have drift again, and now the only epitope we have from the original infection is A. This is the only one we have from the original one. But the body's still like, nope, I'm going to preferentially use my memory cells against epitope A instead of making new memory against E, F, and G. Again, you're fine. Maybe you're sick for like 2 weeks, but your body's, you know what? You're fine. You still handle it. You're still not as bad as the first time you saw it for the first time. But now, here's the last time it drifts. So here's the year 5 with the flu. There's no antigens, like no epitopes that are on the same original virus strain that you saw. And this is what's known as the original antigenic sin. Now we have no protection. Even though we saw E back here, we saw it again, we have no memory against it. We have no plasma cells against it. We have nothing against it because the body preferentially decided to use memory against the other epitopes. So kind of the same idea. E, F, G, H, you have to go through this whole process again, even though you kind of saw these 3 antigens or epitopes for the past 3 years. You still have to go through the whole process again. So you lack B cell epitopes of the original strain. So this is known as the original antigenic sin. Does that make sense? It's kind of like a weird concept to explain. But it's basically like the whole idea of original antigenic sin is the body preferentially decides to use memory instead of making new, instead of going through that whole long process, that whole long primary process, if it has an option, it's always going to choose memory. And this is what becomes really, really important with that's why we need vaccines. A lot of the times the spike protein on the flu isn't going to change drastically. So it's like, why do we need to get flu shots every year? And it's because the body's not going to make new memory against different spike proteins if they're there, because if one is the same, it's just going to keep using the same memory that it has. So you don't want to have this happen, whereas like it just jumps like this and then you have no protection, this, and then you get like a really bad flu. That's like the years that there's really bad flu outbreaks. And then last slide, but in words, and it's the same thing, propensity of the body's immune system to preferentially utilize memory based on a previous infection when there's a slightly different version of that foreign entity, so a virus or bacterium is encountered. So kind of like what I just said here, if you receive the flu vaccine against spike protein A, you encounter a flu particle with spike protein A, B, C, D, and D, you'll only recognize protein A, you'll be protected against it, which is great, but if you see C down the line, even though technically your body has seen it already, you won't be protected against it because you never made that primary response against it. You preferentially used memory against spike protein A. And then this is kind of the same idea. So original antigenic sin, here's like the host, here's immune memory of an antibody or whatever. So here's your virus. So immune memory matching one of the virus antigens prevents training against the other one. So we're going to preferentially use this blue antibody and we're never going to make red. So then if we have a virus that gets rid of all of the blue and only has red, you're not going to be protected against it. Okay. And then here's kind of classic picture. This is everything you need to know, primary, secondary response. So here is your immunization with antigen A. Here's your response to antigen A. And then the second time you see, let's say you see antigens A and B, so you're going to make an even stronger response to A. And then, and you're really not going to do anything with B. That's kind of the idea with antigenic sin, the original antigenic sin. But remember, primary response, first time ever seeing it, it's going to be low affinity IgM. It's always going to be IgM. It's going to be delayed. Remember, it takes about 7 to 14 days to get to like the maximum level you would see. And then the end of this process is to generate memory B and T cells, especially if you have a T-dependent antigen. Versus the secondary response, anamnestic response, all the same things. The second exposure to the same antigen, it's immediate, so it only takes about less than a day to get antibodies produced. Much, much more specific. And you're going to have high specificity IgE produced and much more antibody in general produced. Questions. So why would the flu vaccine force the body to create new responses? Wouldn't the body just respond the same? Wouldn't it try to use memory? Yeah, good question. So you can use different spike proteins. So if you ever get the flu vaccine, so some people like get the flu vaccine, they're like, oh, I'm totally fine after I get the flu vaccine. Nothing happens to me. I don't even get sick. It's probably because the body is using memory. So let's say in that flu vaccine, it was probably all the same, because when they make the flu vaccine, they're guessing what they think the strain's going to be versus like because of what's happening over like across seas, they kind of watch what's happening over there, and then they're like, oh, this is probably what's going to be the flu this year based on how it's happening, because the flu infects birds. So they look at birds, they try to isolate it. They're like, this is probably what the flu is going to be this year. It's really weird. They literally guess when they make the flu vaccines. So they're like, oh, like it looks like it's going to be the same as last year. Let's kind of use the same as last year. Those are when you get the flu vaccine, you feel totally fine after. That's they're using memory. But let's say one year, it's like, oh, we think it's going to be this year. And let's say they inject GE or EFGH antigens instead of ABCD. Then you'll kind of go through that primary immune response. And that's like the people that feel really sick after the flu vaccine that year. So it's kind of like the flu vaccine is going to depend on the type of flu that's there. But yeah, so it really depends on what they think the strain is going to be that year. It's really odd. And does this explain why sometimes colds are mild, sometimes more severe? Exactly. A lot of the times, like the viruses that are affecting you, you might have seen parts of it before, and then the body will preferentially just make a response against the parts that it's seen rather than the whole thing. And then let's say antigenic drift is happening. It's like drifting away. The antigens are mutating a little bit, and now you get like the same virus, but now you have such a like severe reaction to it. It's the exact same thing. That's that whole idea of antigenic sin. Awesome. Yeah, no problem. Okay. And then lastly, types of vaccines. So this is going to be like, these are the different types of vaccines that you can get. And you should know which types are which, but I put here that sometimes terms can overlap. So what I mean by that is like a toxoid vaccine. This is going to be like a diphtheria toxin, a tetanus toxin. We'll talk about the toxoids, but remember what I said, like if you have a polysaccharide vaccine, like a polysaccharide capsule, and you want the T cells to see it, and you want T-dependent B cell activation, you usually conjugate a protein to the polysaccharide, right? Like you usually do that. A lot of the times they use toxoids to do that. So it's like you can have overlap. Like technically toxoids can be a part of conjugates, and just keep in mind that there can be overlap in that way. So just very quickly, so a conjugate, something that improves the immune response. We've talked about this, polysaccharide capsule of strep pneumonia, also like H. influenza and Neisseria meningitidis because encapsulated organisms, but polysaccharides are not recognizable by T cells. So to make it better, conjugate a protein toxoid from tetanus, from diphtheria, from something like that, conjugate it to that polysaccharide, which is going to make that immune response even stronger. Okay, so that's like the idea of like a conjugate vaccine. And then this was kind of like the slide from when we talked about B cell activation. Here's your polysaccharide vaccine. Here's your your T independent is just B cell activation without T cells. So this is like your low affinity IgM. But if we couple it to like a protein, like a toxoid, then you're going to get T dependent B cell activation, which is a much better response. So adjuvants, these again, I talked about them. These are like your annoying sibling that like annoys you to the point where you chase them around the room. Kind of the same idea. So you're enhancing the vaccine solely just by irritating the immune system. You're not making antibodies against it. It's not like a hapten. These are not haptens. You're not making any antibodies. It's not immunogenic because it's just there to like trigger inflammation. And specifically, it's supplying what's known as a danger signal. It's like, oh, this is bad. Like, we need inflammation. So it's going to be like weird sounding things like aluminum hydroxide or, yeah, ASO1. So another way you can think about these is like synthetic PAMPs. And there's a whole, don't memorize these, but I just wanted to show you like there are a lot of adjuvants. A lot of them are like aluminum based, but they're all like weird things. Like they're all weird. You don't have to memorize these, but like these are just, the whole purpose of them getting added is to kind of kickstart your immune response. Okay. So live attenuated vaccines, I put this on here because this is like the best type of vaccine that you can give someone is a live attenuated vaccine. And the reason why is because you're inducing both cellular and humoral responses. So what I mean by that is like a live attenuated vaccine is literally like the virus, let's say it's a virus, that they take away its ability to replicate. So you're literally injecting the virus into the person, but now they can't replicate. So here's an example down here. So pathogenic virus isolated from a patient, and then you grow it in cultured human cells. Then you inject it into a different type of cell. And then you basically like just inject it into the patient, and then it's as if they're actually infected with that virus. So examples of live attenuated vaccines are over here. That's why I gave you the first aid page because of all these mnemonics, because there's a lot of different types of vaccines. But the classic one is MMR. So MMR is like classically known as like it's like the live attenuated vaccine, right? So basically what you're doing is you're taking measles, you're injecting measles into someone, but you take away the ability of measles to replicate. So then you get both antibodies against the measles virus, so you get antibodies against it, and you get a T cell response against it. So that's kind of what a live attenuated vaccine is. And humoral immune responses means like your B cell responses, like you're making tons of antibodies against it. Cellular immunity is your T cell immunity, right? So you're getting like T cells, so again, these are just very, very good to give to patients. So then you're probably like, well, why don't we give this to every patient? Like, why don't we give every single person a live attenuated vaccine? Huge con, may revert to virulent form. Meaning like, yeah, you take away its ability to replicate, but some of these are RNA vaccines. Some of these are RNA viruses. Some of these can randomly mutate, and then one of the mutations might make it be available now to become virulent again and to be able to replicate, which is really bad. Really, really, really bad. So what they say with these live attenuated vaccines, do not give them to immunodeficient patients. Like, do not do that. And don't give it to pregnant patients, because if you give a live vaccine to a pregnant patient, and let's say it spontaneously reverts to the virulent form, now it's going to, it can affect the baby. So that's the issue with live attenuated. They tried to do a live attenuated COVID vaccine, and they just were like, you know what, maybe we don't mess with COVID. Maybe let's not inject COVID to people. We don't even know how this works. But this technically is like the best one that you can give to someone because of this idea of you're inducing both cellular and humoral immunity, T cell immunity and B cell immunity. Does that make sense? Okay. All right. Killed inactivated. These are the more common ones. So this is the flu virus. Yeah, it's super scary. But this is the flu virus. There's a lot of other ones. Another thing I wanted to mention, there's two types of polio vaccines. One is the Jonas's Salk. So when Jonas Salk developed the polio vaccine, it was a killed polio virus that basically he injected. But note, there's another polio. So this guy named Sabin invented a polio vaccine, and he wanted to inject live polio into us, but take away the ability to replicate. So just note, there's two types of polio vaccines. They're different types of vaccine, basically. Different types of virus. But anyway, so influenza is like the big one here. So when you get the flu virus, what they do is they take the flu and they heat and activate it. And when they heat and activate it, they kill it. So it's dead. It can't replicate in this way. It can't spontaneously revert. So it can't revert because it's dead. But you can still make antibodies against this, right? So like, here's like, I really like this picture. So here's like the flu virus. Let's kill it. So we're going to inactivate it using heat. Okay, we make the vaccine, we inject it. You really only get a humoral immune response, meaning a B cell response. You're really only able to make antibodies against the spike protein. That's really all you're able to do. This can't get into cells and then need to invoke a T cell response. You can't do it. It just can't be done. So you're really only getting a humoral response. which is like, it's weaker than your live attenuated, but at least it's safer than your live attenuated. But that's why you need boosters, because we don't get that cellular immune response. We're not getting T cells activated, you know, with the cognate, like the cognate activation on its own. It's not happening because it's not infecting cells. And again, you need T cells to get rid of like the viruses that infect cells. Okay. And then subunit and toxoid. So subunit vaccines are like, they take a, like literally what it sounds like. They take a subunit and they inject that into you. So COVID vaccine, the Pfizer and Moderna COVID vaccines, they took the spike protein, which is a subunit of the whole COVID virus, and they injected it into us basically. Before COVID, the classic ones were HPV and HBV. So Hep B, they take like the antigen, like the surface part of Hep B, they just inject it in you. And same with HPV, they take like certain surface proteins and they inject it in you. These are like the more classic ones. They're like, you're really not going to have like an adverse reaction to it, but they're expensive because again, you're really only taking like a portion of like a full, so you still have to kind of grow up the whole virus, maintain it, and then you're taking only a portion of it. And then there's other types, These are like your polysaccharide capsules. Technically, these are your subunits because you're just taking the capsule. A lot of the times you're conjugating it, right? So we're going to take the subunit and we're going to conjugate it to a protein, but that's kind of the idea of a subunit. And then the toxoid is kind of what I mentioned. So the main two are tetanus and diphtheria, and they're just toxins. So these bacteria produce toxins, and they're just little proteins. So with tetanus infection and diphtheria infection, what makes you sick are these toxins. So rather than trying to immunize us against this whole bacteria, let's just immunize us against the toxin, because that's the point. That's the part that's actually making us sick. But again, kind of like with the subunit vaccines, you kind of need boosters with these because again, it's going to wane over time. You're really only making that humoral immune response. Is an mRNA vaccine another? Yeah, so mRNA vaccines, like, actually, did I put it on here? I did. So mRNA vaccines weren't like a thing, so I don't even think they're in first aid, to be honest. They might be in 2022 version of first aid or 2023 version, but they like weren't a thing before, you know, COVID, really. They're way too expensive to maintain. So they're like their own form. How does the body have memory against capsules if they aren't proteins, even if conjugated? Oh, great question. So you're still going to make antibodies against the capsules. The protein aspect is kind of what just allows it to be loaded onto an MHC class 2 or whatever to activate your T cells. But you're still going to make antibodies against it. It's kind of like that. So capsules aren't haptens, but it's kind of like the same idea of conjugating a hapten to a protein carrier. You're still going to make antibodies against the hapten, right? If you go back to that slide. So and that's what you care about, making the antibody against the hapten. So in this case, what you care about is making the antibodies against the capsule, but you're still going to get capsule conjugate antibodies. You're still going to get capsule antibodies. You're still just going to get the conjugate antibody. Like, you're still going to get those 3 types of antibodies. All we care about is the capsule one. So it's just like a way to kind of like game the system to try and just make like to make it T dependent. But yeah, that's a good question. So capsules really aren't haptens, but you can think of them as being like haptens in terms of like how the immune response responds. Oh, good. So they are in 2022. Cool. Yeah. So mRNA vaccines are in 2022. They are not in my first aid. I don't have first aid 2022. So there they are. So they're new because of COVID. So MHC can present a polysaccharide as long as it's connected to a protein. Yep, exactly. So MHC can basically take it and load it onto an MHC as long as there's that protein there. And we're going to go into haptens a little bit more with the hypersensitivities. That's why I didn't spend too much time on it. And I think we're doing hypersensitivities tomorrow. So I didn't spend too much time on haptens today, but I wanted you to at least see what they were. But yeah, so as soon as you conjugate it to a protein and you make the whole thing now like immunogenic, again, this is just with haptens because polysaccharides are immunogenic on their own. But that as soon as you add that protein to it, now it can get processed and it can get loaded onto MHC. Whereas if you just have like a giant polysaccharide, really the only thing you can do with it is cross-link B cell receptors, and then you get like the low affinity IgM. But if this now had some proteins like on the surface of it here, now like antigen presenting cells can see it, even B cells can see it, load it onto MHC class 2, and then put it on its surface, and then go find like a T cell basically. Okay. I think this is quick. I know there's a lot of slides, but it's very quick. I just kind of want to show you like how mRNA vaccines work, just to kind of tie it together. So here, mRNA vaccine. I also just think this is a really cool vaccine, so I just really, really like it. But the idea behind it is, so again, Moderna and Pfizer, these are the only two that are the mRNA ones. So here's your human, it's my drawn human, getting the mRNA vaccine. This is a single piece of mRNA that codes for a spike protein. So one of the first cells that's going to see it is an antigen-presenting cell. It's a dendritic cell that exists in the skin. It's going to find it. It's going to be like, okay, single-stranded mRNA, this is a PAMP, right? Remember I said there's a bunch of different types of PAMPs. So single-stranded mRNA is a PAMP. It's going to get recognized by a pattern recognition receptor. This can engulf it, load it into MHC class 2, present it to CD4 positive T cells. So now we have T cell activation. So here is MHC class 2 that loaded the single-stranded mRNA. We get signal 1, we get signal 2. We want, let's say we want Th1 positive T cell. So it's going to release interferon gamma, it's going to release IL-12. Let's say we want follicular helper T cells. So it's going to release IL-6, IL-21, and both of these end up being made here. And again, this is not to be memorized. Yeah, don't like this is not like going to be, it's just like, I just want you to see it like all come together. So again, this received IL-12 and interferon gamma, so it's going to upregulate transcription of T-bet to make our Th1 T cell. This guy is going to go and activate macrophages, maybe that have engulfed the PAMP. It can go find CD8 positive T cells and release different types of cytokines to activate CD8 positive T cells, whatever it wants to do. The one that got IL-6 and IL-21 upregulates BCL6, its transcription factor. You make a follicular helper T cell. This is going to go to the lymph node follicle, or any secondary lymphoid follicle, find B cells, and then activate B cells. Okay? So this is going to be part one of like the cognate reaction, right? So it's seeing the specific antigen. So at the exact same time, so this process happened, right? So this process happened, it injected the single-stranded mRNA, and now we have the sentinel cells that are just always kind of around. So one of the sentinel cells is an epithelial cell, right? So the epithelial cell sees it, and it's like, oh, let me uptake this. So it uptakes it, and it literally makes it translates it, and it makes spike protein, and it literally puts spike protein on its surface. And then it also upregulates, it also puts it on an MHC class 1 because now it's infected, right, with this. And it loads it on an MHC class 1. It has spike protein on its surface. It's just a piece of mRNA. It can translate it. So it translates it, it puts it on its surface. Now we have an epithelial cell with spike proteins on its surface. So what both of these things do is it basically gets a CD8 positive T cell, which remember was activated with the Th1 cells we made back here. It's going to go and activate like CD8 positive T cells. So we made that earlier. Now it's like activated, it's patrolling, it sees this MHC class 1, and it's basically going to destroy it, right? So it's going to destroy this MHC class 1. And then from here too, what's cool is from this process, you also get memory. So you get memory CD8 positive T cells that now this is going to be specific for the spike protein. So now let's go back to the lymph node cortex because we made that follicular helper T cell, right? So we made that follicular helper T cell. So in the lymph node cortex, within the follicle, we have a follicular dendritic cell that's now presenting spike protein to a B cell. So now we're going to do B cell activation. So it's presenting it to a B cell. We're cross-linking the B cell receptors. We're activating it. And here's your follicular helper T cell that we made earlier, we activated earlier. It's going to undergo somatic hypermutation. So this is what I think of when I think of somatic hypermutation. It binds with the follicular helper T cell. It gets whatever cytokines. It goes back to the antigen. It like retests the antigen. And it just does this back and forth, back and forth. This is somatic hypermutation. This is affinity maturation. So you're basically making a really strong like B cell receptor specific for this antigen. You're going to get class switching if you need class switching, etc. It kind of goes back and forth within the follicle. And then from here, once it's ready, once it's like, all right, I'm done somatically hypermutating, right? It's going to make memory B cells that have IgG specific for the spike protein, because now memory is specific. And it's going to make plasma cells that are secreting IgG antibodies specific for the spike protein. So again, after some time, you get memory and plasma cells specific for that exact same antigen. So then let's say COVID infects us 3 months later. So COVID's going to come in, it's going to infect us 3 months later immediately, because this is the second time we're seeing this spike protein. This is, again, like the white sheet, right? Like this is the white sheet on the ghost. We get memory B cells that have the specific anti-spike protein antibody. We have plasma cells that are secreting anti-spike protein antibodies. And we have memory CD8 positive T cells. So we not only are making antibodies, that's why people are like, oh, antibodies, they wane. Yes, but we also have memory B cells that can kind of like, that recognize it. We have memory T cells that can recognize it. And then, yeah, we have antibodies that's going to wane over time, but there's still other things that we had made from this vaccine. Okay. I know it's a lot, but it's kind of like, it was no new information. It was all stuff we had talked about, just kind of seeing it now, like clinically relevant, seeing just an example of how the immune system works to kind of fight an infection. And then like one slide on this. So you should know passive versus active immunity. So passive immunity, again, I just use first aid because it has everything you need to know. Passive immunity, think of this as like you're passively receiving antibodies. So like think of antivenom. I always think of antivenom. So antivenom is like if you got bit by a snake and now you have snake toxin floating around in your body, you're going to just get an infusion of anti-snake venom antibodies. That's passive. You're not making anything. You're just passively getting an antibody. It's the same as like IgG crossing the placenta. The baby's not making IgG. It's just getting IgG. IgA in breast milk. So when mom is feeding the baby with the breast milk, the baby's just getting IgA. It's not making IgA. It's just getting it. Okay. This, don't worry about like these notes. This is more of like a boards thing to know like how you treat certain infections. Some of them you kind of have to get antivenom as well as vaccinate. You don't have to worry about that. This is the main thing. What it is, how you get the antibodies, how quickly it works. So passive, it works right away because you already have the antibodies, right? They don't last that long, which makes sense because you're not actively making them. And then examples of it. Versus active immunity, think of active immunity as like an infection. So if you get infected with something, this is like your primary response, right? So that whole process of going through that whole thing of making B cells, making antibodies, making T cells, etc. It's very slow. It takes a very long time to do that. But again, the means of acquisition is just you're being exposed to a foreign antigen, basically. But at least you get long-lasting protection because you get memory. This, if you're just getting antibodies, you're not making memory. They just come in, they do what they need to do, and then they eventually like wean. So natural infection is a good example of this. Vaccines, same exact thing. The primary response of vaccines is a really good example of this. I don't know what toxoid specifically means, but I think it means like the toxoid vaccine as well. I'm not really sure. And again, you don't have to worry about combined. It's just kind of like knowing passive immunity versus active immunity. How is vaccination different from just getting infected with COVID? Like, why is it beneficial to get vaccinated if you already had COVID? Yeah, so the reason why is because they know it's all in the dose. So when you're getting when you're getting the COVID vaccine, you know exactly how many, like basically they know how many memory cells they're going to get, how many antibodies you should make. It's controlled, right? It's like a controlled COVID infection. It's not enough where it's not even the virus, so it's not like it's going to replicate and kill you, but it's a controlled COVID infection, basically, is how you can think about it. So let's say someone had COVID in the past, but it was like I was asymptomatic. I had no symptoms of it, right? Well, then you can say to that person, well, maybe you made no memory cells. Maybe you made not enough antibodies. Like maybe you didn't make any memory T cells. So you can kind of go down that route. You don't know exactly how much they made. versus a vaccine, you know exactly how much memory they're make. That's the whole point of like clinical trials, right? Like they know how many memory cells they should have made, how much antibody they should have made, so forth and so on. So it's that whole idea of like, then people were saying, well, like, let me just go get COVID. You don't know how much you're going to get. Then maybe you're getting too much. And then maybe it's going to be too much for your immune system to handle. Maybe you're going to go into the immune system's going to freak out and just start releasing tons of IL-6 and other cytokines that are going to be really detrimental to your body. So that can be like an argument, like it's not a controlled setting if you're just getting infected with the virus versus the vaccine. This is a controlled setting, but it's also mRNA. It degrades so quickly. So even if you go back to like those notes on like mRNA vaccines, even that is like, that's going to degrade so quick because mRNA is so unstable. So depending on how many, epithelial cells found it and put it on its surface versus how many what's the other one? Langerhans, so the dendritic cells, how many of those saw it and put it on its surface? That's why they do the booster, because they're like, all right, well, the more times the body sees it, let's hopefully they're going to make immune responses. And that's again why people got really sick after the second one, why maybe some people didn't get sick after the second one. Maybe they made a great immune response the first time. It just depends, but it's all controlled. And that's the benefit to doing like the COVID vaccine versus like the natural infection. Technically, if you're naturally infected and they made like a very strong immune response, they should be good. But again, you don't know. Like you really just don't know. J&J, I think, was live attenuated, actually. I think they tried live attenuated, but they were so scared. And don't quote me on this. I'm not 100% sure on J&J. But I think with J&J, they were so scared of COVID reverting because it's live attenuated that they didn't, like, they gave such a small dose of it because they were so afraid of it. But that's why they were saying, like, you only need one dose, because they're like, oh, it's live attenuated. Like, you only need one dose. Those are really good at getting your immune system, like, going. But again, it's kind of like they were so afraid of it that it ended up not working because they were like, and they just didn't give enough, I don't think. Oh, so you got J&J. That's all right. That's all right. It probably didn't do much. They were so afraid of it reverting that they were afraid of it. Guys, I love vaccines. I'm sorry. We spent so much time on that. There are questions. It's up to you if you guys, I mean, I can stay and do them with whoever wants to stay. I can just send them. It's up to you. If you guys want to go, I get it. It's been a very long night. But I'll stay, do them, because then people watching it kind of go back and do them or do them along. But do you guys have any other questions about like just the vaccine response in general? I know it's a lot. I'm very aware. All right. No? Yes? Okay. So yes, no problem. You guys, yes, go if you need to leave. It's totally okay. Even if it's just me on here, I'll keep recording and just do questions. Okay? All right. And I think I'm going to do like a minute instead of a minute and a half. Again, I know that that's not much time, but. Okay, so that was about a minute. Anyone haven't answered that wants to? Go ahead. So basically it's asking the first time you see it, that first peak, primary response versus secondary response. You guys all got so some of you guys got a little confused, but You all at least got the time to the IgG peak was decreased, which is good because you know it happens really quick, the second versus the first. So you can at least cross off all of these. But remember, the peak itself was a lot bigger. A lot bigger. So it's going to be an increased peak in the first one versus the second one. So here's your peak again. So remember the primary response, really low concentration of antibody. And remember, it's primarily IgM. And it takes a very long time. Versus the second response, really short time, the time to the peak. It's going to be a lot, tons of antibody concentration. And then it's primarily going to be very specific IgG. Okay? Yeah, so weak response, very strong, specific response. Quicker, faster, stronger, more intense, more made, all the above. Okay, next. Okay, that was about a minute. Keep working if you're working. Let's walk through it though. So got a older gentleman. He has the flu. His niece had the flu earlier. Cool, but he was vaccinated 2 months ago. But he still got COVID. He still got the flu. So it's like, why do people still get the flu even if they've been vaccinated against it? And this is the whole idea of antigenic drift, which is what A is. So A, your antigenic drift. This is why we have to get the flu vaccine every year. It doesn't work every year because they guess, or there's an original antigenic sin. But still, this is the whole point of it. This is what is responsible for your epidemics, your flu epidemics. So A is your point mutations within the viral genome. This is antigenic drift. Think epidemics with drift. And then shift, antigenic shift, this is your reassortment. So this is when multiple viruses infect the same animal. And that's what's responsible for pandemics. Something like this, where it's like an older gentleman got it from his niece, or I forget what it was, maybe granddaughter, whatever, got it from her. That's more like an epidemic type thing. It's not like a novel flu that they've never seen before ever. Does that make sense? So shift versus drift. Drift is always those little point mutations within the genome. They try to guess the best that they can, but it still can point mutate away from it. So that's drift. I always think of, again, drift is like that antigenic surface is like drifting away. It's drifting away, but it's like, it's not like anything major. Whereas a shift, you're like, whoa, like that's like major new virus. It's not good. Okay. And then this is just another picture. I liked this one better. I love emboss. But again, like antigenic drift, point mutations, they make like some of the surface proteins like look a little bit different, but it's nothing major. It's like a little baby point mutation. Okay. And that's what causes the epidemics. Usually it's when they guess wrong. When they guess wrong for the vaccine, what's on it, it's fine. Versus shift, this is major. 2 viruses, 3 viruses, 4 viruses, whatever, infect the same cell, same animal, same whatever, and then you get a totally just, they've never seen this before ever, and that's your pandemic, okay? So drift versus shift, point mutations versus reassortment. That's like known as reassortment. Okay. Okay, a few more seconds. Okay, yeah, I think I put this in here because I always forget to talk about artificial versus natural, but everyone that answered, you guys are like pretty split evenly. Yeah, so let's talk about artificial versus natural. You guys are split pretty evenly. You got that it was active, which is good. So now it's kind of like, okay, artificial versus active. So, sorry, artificial versus natural. So the reason it's active and not passive is because you're act like you're so we're inoculating this person with it with a virus. So they're going to actively make antibodies. We're not giving them antibodies. We're giving them the virus. Like we're literally like, here you go, here's a virus. So they're gonna actively make antigens again. Sorry, oh my god, antibodies against it. Artificial versus natural is, are you doing this? Like, are you giving them something like a preparation, like an artificial flu virus? Like this is like an H3N2 influenza A preparation. So this is something I'm giving to you. You're not out in the wilderness and you acquire the flu like the vaccine. You acquire the flu. That would be natural. So natural active is like normal infection. So you go out, you get COVID from being out whatever in like a very crowded place, you make antibodies against it. That's natural active. You get the COVID vaccine, that's artificial active. You're still actively making antibodies, but it's artificial because it's in a preparation, it's in a vaccine. It's not just like something you're not like just finding it in the wilderness naturally. That's your, I know I keep saying wilderness, but that's what I think about. Like you're out and about and you naturally get this infection. That's natural. Yeah, stimulate is, oh wait, did I even give you the answer? Sorry. Yeah, stimulate, like this is basically saying like we're giving these Chicago nursing home patients the influenza vaccine. What is a vaccine? And vaccines are artificial active. Artificial passive would be like yeah, like snake venom, like anti-venom. So you're giving no problem. Artificial passive, you're like giving again antitoxin, snake venom, snake anti venom. Artificial because like it's something the hospital itself had prepared, like in a lab, like they prepared it. Preparation is usually a good indication that like something has been done to it, so that's more artificial. But passive would be like I'm giving you antibodies. Like people that get like just infusions of IVIG, so intravenous immunoglobulin, IVIG. That's like when they're like, oh, like just give the patient like that's not IVIG, IVIG. IV immunoglobulin. That would be artificial passive. Like I'm just giving anti-COVID antibodies to these patients as kind of like a way to maybe help them by giving them already pre-made anti-spike protein COVID antibodies. So when they do those infusions in the hospitals, they're trying to do, that's artificial passive immunity. Artificial active is like vaccines. Adaptive immunity is adaptive immunity. It's not what we're talking about here. Natural active, natural infection. You're out and about and you acquire something. Natural passive is like mom. So mom, placenta, IgG crossing the placenta. That's natural. Mom didn't like do, you know what I mean? Like mom is doing that naturally to the baby, right? Like mom made those and now she's giving them to the baby. IgA in breast milk, same thing. That's natural passive. Let's see if it says anything else. Nope, breast milk and then IgG. So that's, yeah, natural passive. So if you just kind of keep those in your mind, like as an examples of all of them, I think you can work through them. Okay. 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 I know it's about a minute. Very quick. Yeah, so I actually got with this one myself when I was picking it. I was like, oh no. So if you guys picked what I picked, yeah. But so basically the key with this one, to induce the maximum immunogenic response. Remember, one type of vaccine maximizes the immunogenic response. And that's kind of what they were getting at with this one. So this answer is actually going to be F. So remember, live attenuated, that's going to be both humoral and cellular immunity. I picked this one because it was a knee jerk reaction. I was like, oh, yeah, you're buying T cells and B cells, right? Yeah, no, remember. So I just really want you to remember, like, live attenuated is the best one if you want to maximize the immunogenic response. Low key, that's why I put this on the slide. That's why you guys don't have it on your slide, but I put it on mine because I really wanted to emphasize that. Because again, you want to activate both humoral and cellular immune responses. So you want to give the live attenuated. Okay. They're really dangerous, but that's not what the question's asking. The question just wants to know, hey, like, how would I get like the most maximal response? And it's live attenuated. Little throwback just to make sure you guys are still with it. Okay, get in your final answers, no looking back. So some of you guys did get gut. It's okay. It's all right. It happens. So what does not perform phagocytosis? Basophils. Basophils do not perform phagocytosis. I know a lot of you guys went for the eosinophils, and you're right. We never think of eosinophils performing phagocytosis. We think these are your mediator releasing cells. But go back to the innate immune lecture. I put it on there because it's like such a random function of it, but they still do phagocytosis. So your neutrophils and your macrophages, these are like your big phagocytosers, right? But eosinophils also do perform phagocytosis. It's not like a huge function of them, but they do. Basophils don't. Basophils are strict mediator releasing cells. So thank you. I just wanted to throw it in here. Yeah, I wanted to throw this in here because I feel like it's something I need to keep reminding you guys of because it's like not a common thing that people remember about eosinophils. Okay, so just kind of review that slide. Put a little star by eosinophils perform phagocytosis. All right. Okay, so this one I gave you that this is tetanus. So this patient has tetanus. This is more of like a boards question where you have to diagnose tetanus. And after this one, there's like 2 more quick ones. No more amboss ones. All right, let's do like 10 more seconds. You guys are all over the place. I love it though. I think we have one answer for every single, like one vote for every single answer. Okay, let's chat. Let's chat. Okay, so tetanus. This was strict recall. I'm sorry. I hate doing strict recall when we literally just learned it that day. But tetanus is one of the ones that's a toxoid. So remember, it's tetanus and diphtheria. These are toxoid vaccines. So kind of like which one of these describes what a toxoid is. And a toxoid, another name to kind of see it, is a denatured bacterial product. So the bacterial product is the toxin itself. And basically it's a toxoid because they denature it. And oid, this suffix, no, is it a suffix? I don't even know. But oid, it means like resembling. That's what this ending to a word means. So it's like, oh, it's resembling the toxin because they denatured it. So they completely denatured it. They took away its ability to be bad, but they're still injecting it into you. So I just kind of wanted you guys to be aware of another way, if they don't say like the toxin or the toxoid, like they can say a denatured bacterial product. This was a little bit of a tricky one. This was tricky. But just keep in mind, like, that's kind of what they do. It's a denatured bacterial toxin. They take it, they denature it, and you should know it's for tetanus and diphtheria are the two that there's toxoids against. Okay. Okay. Guys, it's been a long day. I understand. The brain's not working. Okay, so for this one, basically it's saying like, okay, we're injecting pooled anti-tetanus immunoglobulin around the tissue. So basically what they're doing is they're giving anti-tetanus immunoglobulin. So we're gonna just inject a bunch of these guys. So as soon as you see this, it's going to be passive. As soon as we're giving an antibody, like the patient doesn't have to make antibody, we are giving them antibody, it's always going to be passive. So it's going to be one of these at least. And I thought the trick with this one was these are coming from humans. So you're like, oh, is it natural? Because like they're coming from humans, or is it artificial? And it's artificial still. It's still not you're not out in the wilderness, right? I'm telling you, that always works. Like if you're not out in the wilderness, it's going to be artificial when you're like, well, I guess babies are in the wilderness in mom's womb, right? But still, it's usually natural passive is really only going to be IgG crossing the placenta and IgA with the breast milk. That's really it for natural passive. Everything else is going to be artificial. At least for passive. Does that make sense? But yeah, we're giving antibodies, passive. Passive, the patient is not actively making them, it's passive. These will be great though when you redo them after you had time to digest what just happened tonight. Okay, and then last one. Another little throwback. Okay, about a minute. So remember when we're talking about tolerance, doesn't matter, B cell tolerance, T cell tolerance, whatever. This is the whole idea that we're getting rid of self-reactive T and B cells. That's the whole idea of tolerance. Same with peripheral tolerance, you're getting rid of self-reactive. Central tolerance is straight up like you are deleting T cells that are specific for cell antigens. That's what central tolerance is. You're in the bone marrow, you're in the thymus, you're deleting, you're not even letting them leave. And remember, peripheral tolerance, that's the kind of the idea of like anergy. So like maybe signal 1 without signal 2. Anything that like you're making one of the T and B cells not work once they leave the bone marrow and the thymus. But none of those were even for that. They just straight up were just trying to make like the wording weird. But destroying T cells and B cells that are specific for self antigens, we don't want like specificity for self antigens. So we get rid of them. Okay. What a night, right? All right, let me stop recording.